Okay guys, now we'll talk about the basics of arthritis, how to approach a patient of arthritis. So clinically we can have various classifications of arthritis, like we can have intra-articular versus extra-articular. So what is the meaning of intra-articular means? This is something, so where you will see involvement of synovium. So it will involve synovium. So in intra-articular, you will see involvement of synovium, you will see involvement of articular cartilage, Then you can notice there is like involvement of intra-articular joint capsule, And patient who have intra-articular involvement, you will notice like they will have a diffuse deep-seated pain. So pain will be on active and passive motion. Sometimes you can see localized swelling around the joint, and you can see it can produce a noise while joint movement. We call this crepitus. That sound is called crepitus, and deformity may be present. And when you compare this with extra-articular, in extra-articular, remember, mainly it will involve your tendons, muscles, ligaments. So mainly you will see tendons are involved. So extra-articular will involve tendons. Then remember, it can involve muscle and fascia. And it can also involve your ligaments. And when you see like these patients, so they will have more of a localized superficial type of pain. So they will have a localized superficial pain. Now another listing, and this pain is generally, remember, pain is generally on active motion. So pain mainly on active motion or active movement. So sometimes you can see localized swelling that is away from the joint. Then how else we can classify? We can say, like, suppose if you are having synovial involvement, and this is like a chronic process, means more than 6 weeks. So this chronic synovial involvement, this is something which we see in autoimmune connective tissue disorder. So it is something which we see in autoimmune connective tissue disorders. That is chronic synovial involvement. So it can progress to synovitis, that we see in rheumatoid arthritis. It can lead to synovial hypertrophy and sometimes bone erosion. Now coming to articular cartilage. So understand, this articular cartilage, this is something which is affected, or I can say damaged, in a patient of osteoarthritis. In a patient of osteoarthritis, you will see articular involvement. And what will be the features? We will see there will be like a loss of joint space. There will be loss of joint space. Sometimes you will notice like there is a formation of osteophytes. So sometimes they will give you a clinical question and they will ask you, and you will notice like there is a subchondral sclerosis. So sometime in clinical case, what they give you these things as hint in the MCQ. And they ask you what is the diagnosis. So these are features of osteoarthritis. Then remember, if you ask me, synovitis means involvement of synovial space. So this is something which we see in a patient of RA, rheumatoid arthritis, and sometimes you can see it is seen in a patient of SLE. And even SLE like condition like a Sjogren syndrome, polymyositis, rheumatomyositis. Then we can also classify this as spondyloarthritis. So the spondyloarthritis, understand this thing here. What we can say here, you will notice there is synovitis is there, but along with synovitis, you can notice like patient will have either enthesitis or I can say dactylitis. So there will be enthesitis, and some people plus minus I will say dactylitis. So this will depend on like what type of skeleton is involved. Suppose if it's involving your axial, we call this axial spondyloarthritis. So it is something which we see in a patient of ankylosing spondylitis. And we can see this like patient will have sacroiliitis. When I talk about peripheral type of spondyloarthritis. For instance, periphery means this is something which we see in the patient of either like seronegative type of arthritis, like psoriatic arthritis, or I can say a patient of reactive arthritis. So just understand this thing: psoriatic arthritis, or I can say reactive arthritis. So reactive arthritis, we also call this Ritter syndrome. So here you will see mainly your axial, we will see like a peripheral type of spondyloarthritis. But in case of ankylosing spondylitis, you will see is something that's involving your axial, means it's involving your back, spine. And when you talk about, I can say psoriatic reactive, it involves your small fingers or sometimes like lower limb. The next type will be crystalopathy. So it is a synovitis due to crystals. So we can have two type of crystals. First is called monosodium urate crystals. Monosodium urate crystal, it is something which we see in a patient of gout. MSU, in short we call this MSU. Second is calcium pyrophosphate. We call this CPP, calcium pyrophosphate, and this is something which we see in a patient of pseudogout. So the main question they ask you in exam, like suppose sometimes we classify this like inflammatory or non-inflammatory, and they ask you a question like how to differentiate these from rheumatoid arthritis. So when they ask you like what is most common inflammatory arthritis, so answer is rheumatoid arthritis. And after this you can see information where in Sjogren syndrome induced arthritis. So most common will be RA. And they ask you most common non-inflammatory, this will be your osteoarthritis. So now let us understand this thing, how we compare this with rheumatoid arthritis. So rheumatoid arthritis characteristic basically we want to understand. So starting with the first one, suppose if they ask you site of involvement in rheumatoid arthritis, is it intra-articular or extra-articular? So this is a differentiate. This is actually needed to differentiate like joint or soft tissue involvement. So here you will see intra-articular involvement. You will see it is a type of intra-articular, and you will notice tenosynovitis. Then they ask you nature of disease. Now see, rheumatoid arthritis, is it inflammatory or it is non-inflammatory? So I told you non-inflammatory is your osteoarthritis. So rheumatoid arthritis is basically your inflammatory type. It is your inflammatory arthritis. There is inflammation. Then they ask you laterality, means unilateral or bilateral. So when you see osteoarthritis is mostly unilateral, but remember it can also be bilateral. But if you ask me rheumatoid arthritis, it will involve both, means it will involve both hands. So it is basically your bilateral. So why this is important? Because it will help to distinguish autoimmune disorder from some mechanical disorder that can lead to arthritic change. Then another thing, they ask you symmetrical or asymmetrical. So remember most autoimmune disorders, so mostly they are symmetrical. So rheumatoid arthritis is also causing symmetrical arthritis. Then what they ask you like limb predominance. So when you say like arthritis like reactive arthritis, septic arthritis, osteoarthritis, which is I'm writing here, arthritis like reactive arthritis, septic arthritis, crystal arthritis or gout, pseudogout, and even your osteoarthritis. These are having lower limb involvement. But if you see rheumatoid arthritis, then I can say psoriatic arthritis, they will have predominantly upper limb involvement, right? Upper limb involvement. So this actually start from your hands and wrist. We can see mainly it will involve your MCP and PIP. So MCP and PIP are mainly involved, and DIP is the one which is mainly involved in psoriatic arthritis. So DIP is paired where in a patient of rheumatoid arthritis. Now coming to number of joint involved. So when you see a patient of rheumatoid arthritis, remember it's always a polyarthritis. Polyarthritis means you will see more than one joint. Monoarthritis is generally we see in a patient of osteoarthritis and septic arthritis. So understand this thing, this is needed to quantify the disease. So rheumatoid arthritis is always remember it is polyarthritis. Now coming to joint size affected. So when you talk about small joints, remember in most autoimmune disease you will notice small joints are affected where in rheumatoid arthritis, SLE, and large joint you will see where in osteoarthritis and spondyloarthritis like ankylosing spondylitis. So here you will always see like it will involve your small joint. And what are the most common joint I told you? So remember it will involve MCP, it will involve PIP, and what is not involved, just I'm writing here, rheumatoid arthritis, it will spare DIP. And DIP is most common joint involved where in a patient of psoriatic arthritis. Now coming to pattern of involvement, is it axial? So axial we see where in spondyloarthropathy. So is peripheral? Answer is yes. So mainly remember it is your peripheral type. So it is affecting small joint of your upper limbs mainly. So these are the differentiating feature of osteoarthritis from these are actually different feature which can tell you more in detail because they ask you question on rheumatoid arthritis. Now sometime what they ask you like what are common knee joint condition. So just first I'm writing here, suppose you are having a patient who is having knee joint involvement. So what are the hints you need to see in the question? First they will give you a clinical case like a patient is coming to you with a knee pain. So suppose let me say there are multiple hints. So first hint what they ask you, they give you suppose this is a patient who is having high grade fever, a very high grade fever, or I can say patient WBC, TLC is very high. TLC means a total leukocyte count, these are high. Then you can notice like these patients will have a swollen red or erythematous joint and very painful to touch. Means patient when you touch his or her knee, he will immediately just shout in pain. That is called a painful, very painful. Then you can later on do the synovial fluid analysis, but remember by the symptom also we can get an idea. So this is something what we call this septic arthritis. So septic arthritis patient will come to you with high grade fever, there will be swollen joint, there will be erythematous joint and extremely painful to touch. Suppose if they mention like patient is having some sort of crystals, and these crystals are mainly calcium pyrophosphate crystals, then they can mention like this patient is having some sort of kidney stones, means there is associated illness like kidney stone, like patient is having idiopathic hypercalciuria, so that can lead to calcium oxalate stone. So patient also have kidney stone, right? But if you see like otherwise there is no as such swelling, there is no painful, so this is suggestive of your pseudogout. But suppose if they give you in a clinical case like patient having knee joint involvement and there is a prior, so patient had a prior STD, means some chlamydia infection, or I can say some other Neisseria infection, or I can say patient had some prior gastroenteritis. So prior gastroenteritis with Salmonella, Shigella, or sometimes they can give you like prior Yersinia infection, or even some people they can have prior respiratory tract infection with mycoplasma. So question will be coming like this, like a patient is having a knee pain few weeks before he developed respiratory tract infection, or I can say he developed some gastroenteritis. So this is suggestive of your reactive arthritis. It is suggestive of reactive arthritis, and what we call this? We call this Reiter syndrome. But suppose if nothing is given, and they have given like some hint like patient is obese, patient is smoker, or patient is having a job of prolonged standing, so that is mainly the most common thing. This is your osteoarthritis. So these are the 4 conditions. Just remember, in all these conditions the most common joint involved is knee joint. Is clear? If nothing you are getting, just pick the answer osteoarthritis. So now what they ask you normally when you see, so when you see like gross appearance of I can say synovial fluid, it is clear, viscosity is slightly high, WBCs are less than 200, and out of this polymorphs are less than 25. In polarizing microscopy you will see nothing, so negative pattern. When you see in osteoarthritis, understand this thing, you will notice only WBCs will be slightly more. right? WBC will be slightly more. So that is a feature. Then in inflammatory arthritis, inflammatory like in a patient of any autoimmune disease, you will notice the gross appearance will be cloudy or opaque. Then you can notice like cells, WBCs are more, polymorphs are also more, and they are positive for certain crystals. Like in gout, you will find, I can say in gout you will find monosodium urate crystals. In pseudogout you will find calcium pyrophosphate crystals. If you compare the septic arthritis, you will see the WBC count. When you see this WBC count, it is very high. Clear? So this is very high in the synovial fluid. It's also very high in the CBC report. Then you can notice neutrophils are also very high. But in case of microscopy, polarizing microscopy, it's showing negative. So these are your differential diagnosis of knee joint, which you have to remember. Now, understand this thing. They ask you like how we differentiate gout from pseudogout, and this is something which they ask routinely in exam. So when they talk about a patient who's having gout, so gout is generally affecting males in their age group of 40 to 60. So a patient will come to you with extremely painful arthritis. So you can notice like acute, hot, dusky, red swollen joint. Red swollen joint. So this will be the feature, and this patient understand this. He will tell you like, I am having this pain today because yesterday I have taken alcohol. So patient will have some, remember, there will be increase in pain whenever he consume alcohol, means patient will be alcoholic, and mostly like this occur because of binge episode of alcohol. Means suppose patient will tell you like, last night I had my friend wedding, so I have taken a lot of alcohol. So next day you will notice like all of a sudden like joint, this the first MTP, the most common joint I will say is first MTP. First MTP, this most common joint in gout, or I can say great toe. So this become red beefy swollen. In pseudogout you will see most common joint. Most common joint will be in pseudogout. Yes, very good. Knee joint. You will see knee joint. Now, other than this thing, you can notice the crystals. So when they ask you crystals, so what I told you before, the crystals you will see here will be MSU. MSU means monosodium urate crystals. Here you will notice crystals, we call them CPP. CPP is calcium pyrophosphate crystals. And these crystals, when you see in microscopy, they look like a needle. Their appearance will be like a needle. So these are needle shaped crystals. In I can say pseudogout, you will see the crystals, they look like rhomboid. So you will find patient will have rhomboid crystals. Now coming to birefringence pattern, so these are like monosodium crystals, and they will have a negative birefringence. And pseudogout, here you will find weakly positive bifringent crystals. Then again, most common joint, what I told you, it's first MTP. Here it will be knee joint. Now what you will find in X-ray. So when you do X-ray of a gout patient, understand, you can find some punched out lesion. We call them rat bite erosions. But again, these are not a classical finding. The classical finding you will find is like a periarticular erosion. So they look like an overhanging edges with sclerotic margins. We will notice overhanging margins, or I can say overhanging edges with sclerotic margins. This is what we call this Martel sign. So we call this Martel sign, or what we call this G sign. Martel sign or G sign. In pseudogout, what you will notice the X-ray will have chondrocalcinosis. Chondrocalcinosis. So let me just show you these signs. So look at the skin carefully, try to understand. This is your chondrocalcinosis in a patient of pseudogout. Then what you can notice in a patient who is having gout, this is what we can see like overhanging edges with sclerotic margins. So these are what we call this gout, and you can see a painful red swollen joint. This is called Martel sign or G sign in X-ray. So in acute gout, the purpose of treatment will be we have to make the patient pain free. So in acute gout, what we do, the goal of management is to make the patient pain free. So this is the ultimate goal. And in chronic gout, the goal is, understand this thing, like you should not develop later on complication. So what they ask you, suppose if a person is having acute gout, the initial drug that we use will be NSAIDs. So we have basically three options. So we can use NSAIDs, And the most preferred NSAID that we use, this is your indomethacin. Indomethacin. So just remember, it is like based on the preferable site. So indomethacin we prefer in a patient with joint pain. Then remember, ibuprofen we prefer in a patient with tooth pain, and naproxen we prefer in a patient with head pain. So other than NSAID, what we can use? We can use steroid. So we can use like oral or intra-articular or intralesion steroid, and we can use a drug called colchicine. So these are three possible options. Now listen, we can use NSAID, but generally we avoid giving aspirin. Why we avoid aspirin? Because understand this thing, this aspirin is something which can further deteriorate the symptom. Like this aspirin can decrease uric acid excretion, so it will try to accumulate uric acid more and more, right? PCM is actually we avoid because PCM is not a strong painkiller, so that's why it's having a mild inflammatory property and mild analgesic action. That's why we don't recommend. So these are three options. So first will be NSAID, second will be your steroid, third will be your colchicine. Okay, they ask you like how we will use colchicine. So this colchicine, it will block microtubules, it will block chemotaxis. So ultimately neutrophilic recruitment is affected. So this is like what we use. We use this in acute gout. So just remember a rule of A to C. A to C means in acute gout we use colchicine, and C to A, in chronic gout we use allopurinol. A to C, acute gout colchicine, chronic gout allopurinol. Simple. A to C, C to A. So now coming to this, other than this thing, this is very effective drug, but it is a reserve drug. Why it is a reserve drug? Understand this thing. It's a reserve drug because it can cause a serious side effect. Like some people, you will notice after taking colchicine, they can develop uncontrolled diarrhea, and even it can cause agranulocytosis. So this is one reason we do not give this to every patient. So it can cause agranulocytosis and diarrhea. So these are side effects of colchicine. Now when they talk about chronic gout, so how we manage chronic gout? Understand, in chronic gout, understand this thing, the goal is to further stop the progression of disease. So here the goal will be to stop disease progression, because what will happen if disease will progress? So it can affect your kidney. Then sometimes patient can develop like TOFI, we call it chronic advanced form, we call it tophaceous gout. So here what we give, so in chronic gout you can say advanced form, you can see TOFI formation, right? It can lead to stone formation. Now what they ask you, like what we give allopurinol. So what is allopurinol? Understand this thing, this is something called xanthine oxidase inhibitor. So it will inhibit xanthine oxidase. So when it will inhibit xanthine oxidase, what it will do? This will decrease uric acid production. Right? So now just try to understand this thing. Just imagine this. First comes this drawing, then I'll come back to the theory part. We have purines. Purines will convert into hypoxanthine. Then we have an enzyme called xanthine oxidase that will convert hypoxanthine into xanthine. Then you will see xanthine is converted into uric acid. So the ultimate goal in human beings, remember, ultimate end product will be uric acid. But suppose like we have bone marrow in our body, that is the site of production of your RBCs, WBCs. Similarly in birds, what do they have? In birds they have something called cloaca. This cloaca of bird is equivalent to bone marrow of human beings. So they have additionally an enzyme. This enzyme is called uricase. So now what uricase will do? Uricase enzyme will convert uric acid into allantoin. Now understand. So in chronic gout, what are the options? What are the possible options we have? So let's see. First option, we can decrease the production. So how we can decrease production? So we can inhibit this enzyme. Which enzyme? Xanthine oxidase. So when you inhibit this enzyme, uric acid will not produce. Simple. So this is first group of drug called xanthine oxidase inhibitor. Second is, understand, second is what we can use. We can use some drugs which can flush the uric acid out of the body. So that is what we call them like a uricosuric. So like diuretic, they will flush water. Uricosuric means they will remove uric acid. So we can use uricosuric drugs. So they will remove uric acid in the kidney. And these drugs, what we call them uricosuric drugs. Like we have probenecid, sulfenpyrazone, benzabromarone. Even like antihypertensive losartan will have this action. Now understand this thing. But suppose there is no improvement coming. So third option is what? We have to give something which act like uricase. So what is this? This is called recombinant uricase. So this is like a product of DNA, recombinant DNA technology. So that will be expensive. So we have drugs like rasburicase, pegloticase. Okay. So what they will do, they will convert that uric acid and they will convert it into allantoin. So this is the mechanism that we need to understand. So understand. Now allopurinol. So allopurinol, where we use? So it is used in treatment of hyperuricemia in patients with gout, and sometimes like we use this in those patients like who are suffering from some hematological malignancies and they are about to undergo chemotherapy. Other drugs which are like similar to allopurinol, these are oxypurinol and febuxostat. Now understand, allopurinol is a drug which is slightly nephrotoxic, so it will affect your kidney. It is a drug which will affect your kidney. So if any patient who is having deranged KFT, means whose patient will see urea creatinine is increased, in that case we preferred febuxostat. So this febuxostat is preferred in patient with deranged KFT. Deranged KFT means either in AKI patient or CKD patient or in those patients who are having slightly higher BU and higher creatinine. Simple. Then we can use uricosuric drugs like probenecid, sulfenpyrazone, benzabromarone, lesinuride. So they can precipitate, like when they are taking uric acid from the blood to urine, sometimes that can stuck in the kidney. So that can lead to risk of urate stone. Then remember, they ask you one more thing, like there is one more drug called losartan. So losartan is your, yes, it is your ARB. So this losartan is something which is having uricosuric action. So it is also having uricosuric action. So this is reminding me of a question which came in exam. Like the question is like, suppose you are having a patient who is having gout as well as hypertension. So they ask you gout and hypertension, which antihypertensive you will choose? You will choose losartan, because losartan will control both. It will control hypertension as well as gout. So what is the preferred antihypertensive in a patient of gout and hypertension? Losartan. Then try to understand. They ask you like what are recombinant uricase. So these are uricase analog, means these are recombinant uricase. Recombinant uricase. And here we have two drugs like pegloticase and rasburicase. Pegloticase and rasburicase. So understand this thing, these uricase analog or recombinant uricase you will not give to every patient. Why? Because understand, first, these are drugs which are quite expensive. And second, like these are not available in oral form. So they ask you like, what is pegloticase? So what pegloticase, uricase, what actually all these are doing? They are catalyzing oxidation of uric acid to allantoin. So they will convert uric acid into allantoin. So where we use them? So we use these drugs in two conditions. So first is we use this in refractory gout. Refractory gout means gout which is not being treated by normal conventional drugs. Then understand this thing, we can use this like in a patient with refractory gout, and sometime in a patient like who have TLS. What is TLS? TLS is tumor lysis syndrome. Right? In asymptomatic hyperuricemia, what is contraindicated? Remember, this is a very common, I can say, malpractice which people do. Some people, they have asymptomatic hyperuricemia, uric acid slightly increased. What are treatment? Treatment is water. You have to give a lot of water. That's it. It is because your body is, you are not taking enough water. Now coming to rasburicase. So rasburicase is considered drug of choice in same tumor lysis syndrome, right? And just remember, this is something. Tumor lysis syndrome is what? Just try to understand this thing. Tumor lysis syndrome means whenever we give a chemotherapy, or I can say radiotherapy to a tumor, so this tumor cell will break, and this break, and it will lead to different electrolyte imbalance. So patient can develop hypernatremia, patient can develop hyperphosphatemia, patient can develop hyperuricemia, means increase in uric acid. Even sometimes you can notice increase in phosphate. And remember, calcium is decreased. So these are the component of tumor lysis syndrome. So just remember, in tumor lysis syndrome, whenever you give chemotherapy or I can say radiotherapy to a patient, this will break the tumor cells and it can lead to electrolyte imbalance. So they ask you tumor lysis syndrome, all are seen except, so answer is hypercalcemia. Calcium will be low. So raspberry case, Peglosti case, where we use in a patient who is having refractory gout and a patient with tumor lysis syndrome, and both these questions also came in exam. Right? So whenever you see patient having CLL or CML, many leukemia, suppose we start a chemotherapy, that can lead to TLS. TLS means it is one of the oncological emergency. Generally in oncology we don't see emergency. So just remember, very few conditions like tumor lysis syndrome, then there is one more superior vena cava syndrome. So that is some sort of oncological emergency. Means now this cancer patient we need to admit in ICU. We call them oncological emergency. And now we have to treat all the ionic imbalance, all we have to treat. We have to treat hypernatremia, we have to treat hyperkalemia, we have to treat hyperuricemia, we have to treat phosphate, calcium, everything. Okay, now coming to they ask you suppose in a patient we start allopurinol. So before this, what we check? We check for an HLA that is called HLA B5801. HLA B5801. Because suppose very few people they have a HLA, in that case it can trigger Stevens-Johnson syndrome. This is something which is very, very important. Now what they ask you suppose there is a patient who is having I can say B5701. In these patient, when you see B5701, this HLA, remember, patient should avoid abacavir. So abacavir is something which is avoided in this patient. Okay, now coming to drug interaction. So when you see whenever you give allopurinol or febuxostat, then this will inhibit the metabolism of some certain other drugs like 6-mercaptopurine or azathioprine. So understand this thing, when you use allopurinol with these drugs, there is a chance it will increase their toxicity, right? And it will decrease the dose of these drugs, means it will decrease the actually effect of these drugs when they are given in combination. So there is more chance of toxicity and less efficacy when you combine allopurinol with 6-mercaptopurine or azathioprine. Now let's talk about rheumatoid arthritis. So they ask you, rheumatoid arthritis is one of the common chronic autoimmune disease. So what is the name of HLA? So first HLA what they ask you in exam is HLA DRB104. And the common which they ask in exam is HLA DR4. Even some cases are also having HLA DR3. So DRB104, HLA DR4 is HLA. Now if you see the inflammation, the main classical finding will be patient will have joint pain, and this mainly will involve smaller joint. And this joint pain will also have morning stiffness. Just remember, this morning stiffness, it will last for more than 45 minutes. So patient will have morning stiffness, and this morning stiffness is lasting for more than 45 minutes. Now understand, so patient is having morning stiffness along with joint pain. So erosions, these are juxta-articular osteopenia, and a patient can develop a lot of deformities due to erosions. So pain is more on rest, and this will improve. This is improved with activity. It is improved with activity, or I can say by evening. So patient will have more pain in the morning. As soon as she is doing some work, for suppose like a female, she is telling in the morning, I cannot cook food for my children because I am having pain and his stiffness. But by the evening she is fine. Now they ask you joint involved. So most common joint involved, this will be your MCP. Then you can see patient can have involvement of wrist joint. There is involvement of PIP joint, and it's also involving your C1 and C2 vertebra, means cervical spine. And in the cervical spine, remember C1, C2. Now they ask you what is a joint not involved. So it will not involve first CMC, first MTP, thoracolumbar, and cervical spine. And the classical finding which is not involved, that is your DIP. And just remember, this DIP is most common joint. It is most common joint involved in psoriatic arthritis. So DIP is something which is not involved here, but most common in psoriatic. So you can notice like there will be symmetrical joint space reduction. So there is a simple bone erosion and it can lead to bone displacement as well. Now what they ask you about psoriatic arthropathy. So understand this thing, psoriatic arthropathy, here you will see there is inflammation, we call this periostitis. So there is periostitis. Along with this, you will see there is like a destruction of bone. We call this osteolysis. There is osteolysis. Then you can notice like it is also a type of symmetrical arthritis. So you can see it is symmetrical arthritis, or basically multiple joints are involved. So we call this symmetrical polyarthritis. Now, understand this thing, in psoriatic arthropathy, patient will be having a past history. So just I'm writing here, there will be a past history of, or I can say, there is a family history of psoriasis. So patient will have some past history, or somebody in the family is having history. Or maybe patient is having current psoriasis, maybe right now he or she is having psoriasis. So in psoriasis means that skin finding, like silvery scales in the skin. Then you will notice some of the nail changes. There will be certain nail changes. Nail changes means these nail changes you can remember by mnemonic poo. Poo is pitting of nails. There is pitting of nails. Then you can see there is onychorexis. Means there is like a partial separation of nail from nail bed. You can see onycholysis. Onycholysis is something which is a complete separation of nail from nail bed. And we can see sometimes this nail will look very dirty, oily, yellow, tan discoloration of nail. We call this oil drop sign. So you can see patient will have family history, past history of psoriasis, current psoriasis. We will see some nail changes and you can see like a new bone formation. So these are the features, and these features, understand this thing, what we call this? We call this a diagnostic criteria, and this diagnostic criteria is called as Casper criteria. So Casper criteria is used to diagnose psoriatic arthritis. Then patient will have X-ray pattern. So what they ask you, you can see like there is involvement of DIP. So DIP is most common involved. Then you can sometimes involvement of PIP and MCP joint. So most common will be DIP. Then sometimes you can see marginal erosion with adjacent bony proliferation. We call this whiskering of joint. And sometimes we will see a deformity. We call this pencil in cup deformity. Pencil in cup deformity. And you can see the phalanx will be looking very thick and big in the middle part. This is what we call this ivory phalanx. So we call this ivory phalanx. Then you will notice like patients, some of these patients, they will have a severe deformity. The severe deforming type of psoriatic arthritis, we call this arthritis mutilans. We call this as arthritis mutilans. So what is arthritis mutilans? Understand, arthritis mutilans is severe form of psoriatic arthritis. Then you can see nail changes. Nail changes we have discussed, like there will be pitting of nail, or onychorexis, onycholysis, oil drops, and these are nail changes. And you can see sometimes telescoping of digits. Now what they ask you a question like, suppose a question on Jacquard's arthropathy. So what is Jacquard's arthropathy? So Jacquard arthropathy is something which we see whenever a person is having two autoimmune diseases like SLE and RA together. So basically it is a non-erosive type of arthropathy. So it is a non-erosive deformity, and this non-erosive deformity it occur due to laxity of ligament. Due to laxity of ligament. And in Jacob arthropathy, you will see again MCP, wrist, PIP, cervical spine, these are commonly involved. So these are the findings which we see. So you can see this is like severe deformation in a patient of psoriatic arthritis. What we call this arthritis mutinans. Now coming to chronic non-inflammatory arthritis, that is your osteoarthritis. So osteoarthritis, they ask you what is most common joint. So just if I write the sequence, so just remember most common joint involved will be knee joint. After knee, I can say it is involving your hip joint. Then it can involve sometimes smaller joint, like you can see DIP, you can see PIP involvement, and even like I can say post CMC involvement. So when they talk about a DIP PIP involvement, so what we find some small nodule or some small node in these areas. So suppose if you find these nodes in PIP, these are called Bouchard node. And when you find this node in DIP, we call them as Haberden node. So these are some of the questions which they ask in exam. So there is asymmetrical loss of joint space, and sometimes you can find subchondral sclerosis, you can see cyst, and you can find the classical finding which we call them osteophytes. So these are the features that we see in a patient of osteoarthritis. Then there is a type of arthritis, we call this like a Chiroarthropathy. So we have different name for this. We call this, it is basically like joint and nerve involvement. We call this like arthroneuropathy, or we call this chiroarthropathy. Chiroarthropathy. We also call this as Charcot joint. So in these, what you will notice there is a destruction of joint, but it is painless. It is completely painless. Means there will be no pain. In rheumatoid arthritis, you will see patient will have deformity, but that deformity will have pain also. So this is what we call here, because of neuropathy they will not have pain. We call this painless destruction of joint. It is painless destruction of joint. So understand this thing, this chiroarthropathy you can remember by 5 Ds, means you will see disorganization, you can see density, there is destruction of joint, there is debris, and there is distension. And most common cause is again D. So most common cause will be diabetes. Then remember, it can also be seen in a patient of amyloidosis. You can see this in a patient of tabes dorsalis. You can even see this in a patient of like syringomyelia. It look bad but doesn't feel bad, means we call this painless destruction. Now what they ask you in exam, they ask you, suppose like if a person is having chiroarthropathy, so what is most common? So most common finding we will see, it is involving your metatarsals. And one more question, this remind me, like this question came in FMG exam, like patient cannot properly fold their both hand. So this is what we call the best. If you are doing this, I have doing namaste like this, namaskar like this, but patient cannot touch both the palm together. This is what we call this namaskar sign or prayer sign. So in chiroarthropathy, they ask you like patient will develop, so patient actually cannot do namaskar. So we call this namaskar sign, or we call this as prayer sign. So prayer sign, namaskar sign, it is seen in patient of chiroarthropathy. We also call this Charcot joint. And just remember, the most common cause will be diabetes. Then sometime very rarely you will see like in some, I can say, bleeding disorders like hemophilia, you can see blood is accumulating in the joint. So that is what we call this hemophilic arthropathy. So in hemophilic arthropathy, what they ask you, hemophilias, so these are seen in a patient of hemophilia. So hemophilia, just remember we have two types of hemophilia A and B. These are common types, so which is X-linked recessive. So hemophilia A and hemophilia B, these are X-linked recessive. Hemophilia A we call this classical hemophilia, B we call this Christmas disease. So mostly you will see these patients are male. X-linked recessive will affect only males. But there is one more type called hemophilia C. We also call this Rosenthal syndrome, that is also recessive, so that can affect both boys and girls. Then patient will have knee. So basically what you are noticing here is there is hemarthrosis in the knee joint, and when you see this knee joint, you can see like the patella will be looking squared. So you can see squared patella. There is squared patella, and sometimes you will notice like there is intracondylar notch widening. There is intercondylar notch widening, and sometimes it look like a pseudo tumor. So this is about your hemophilic arthropathy. Sometimes we also call this hemarthrosis that we see in a patient of hemophilia. So these are your findings. Then we have a rare type of arthritis. We call this juvenile idiopathic arthritis. In short, I will call this as JIA. So juvenile means patient will be younger. So again, we have two types like oligoarticular. Oligoarticular means you will see less than 4 joint involvement. And this is actually most common type. Most common type will be oligoarticular. And sometimes what we see polyarticular. Polyarticular means you will see more than 4 joint involvement. So most common type will be oligoarticular. So you can see like rheumatoid factor, it can be rheumatoid factor positive. So in that case we call this JRA. In that case we call this JRA means juvenile rheumatoid arthritis, and sometimes it can be negative. Then sometimes you will see systemic. Systemic means here you will see some systemic symptom. In normal types you will not see systemic symptoms. Now what are systemic symptoms? You can see patient will have fever, and along with fever you can see rash, hepatosplenomegaly, there will be lymphadenopathy, serositis like pericarditis, pleuritis. And to ask you how you will treat this. So how we treat this? We give DMARDs. So in treatment we give DMARDs means we can use methotrexate, and sometimes it is not controlled, then we will add biologics drugs. Biologics means these are the drugs basically which they act on TNF, anti-TNF drugs. Now we'll talk about spondyloarthropathies. Now understand what is the meaning of spondyloarthropathies. Like we can divide this into two categories. One that involve your axial skeletal, and second that involve your periphery. So in axial type what we have? In axial type we have ankylosing spondylitis. So we also call this like radiographic spondyloarthritis. Why we call this? Because you will see the classical MRI is the basic test. In MRI you will find sacroiliitis. So in this you can see the classical association will be HLA-B27. So just understand this thing. Suppose in arthritis when you see rheumatoid factor is positive. If rheumatoid factor is not positive, then what we see? Anti-CCP is positive. So rheumatoid factor or anti-CCP, any one of them is positive. Those arthritis, understand what we call? We call them seropositive. These arthritis are called seropositive. And when this factor is negative, so rheumatoid factor or anti-CCP, CCP, I'll discuss this in rheumatoid arthritis, it is cyclic cytinary peptide. When these are negative, we call them seronegative. So understand this thing. Whenever you are having a patient with seropositive arthritis, the seropositive arthritis, the classical example will be rheumatoid arthritis. And the HLA which I told you, that HLA is HLA-DR4. Sometimes you can see HLA-DR3 as well. And there is one more, HLA-DRB104. Seronegative arthritis will not have the HLA positive. So in seronegative arthritis, here you will see the HLA which is positive. This HLA is called HLA-B27. And this HLA-B27, so these are basically HLA-B27 will be positive here. And these arthritis we call them seronegative or HLA-B27 positive. So these you can remember by mnemonic Jaipur. Now what is Jaipur? Understand Jaipur. First J is JRA. JRA is juvenile rheumatoid arthritis. A is ankylosing spondylitis. I is IBD arthritis. IBD arthritis means inflammatory bowel disease. Like you can see some people with Crohn disease, ulcerative colitis, they can develop arthritis. We call this IBD. Then P stands for psoriatic arthritis. This U stand for, I can say, undifferentiated arthritis. And this R will be your reactive arthritis. R is your reactive arthritis. So understand this thing, just mark my word, juvenile rheumatoid arthritis can be seronegative, but adult type is seropositive. Out of this, what they ask you, out of all these seronegative, which is having maximum association with HLA-B27, so answer is ankylosing spondylitis. So this question also gave me NEET PG once. like HLA-P27 maximum association you will see in a patient of ankylosing spondylitis. Now see, the patient will have a bilateral sacroiliitis. So because of bilateral sacroiliitis, this patient will be complaining of lower back pain. So patient will tell you, I'm having pain in my back. Then they can develop some, I can say, extra articular manifestation. So commonly what we see, you can see patient can develop asymmetrical. So there will be asymmetrical, means one-sided. Then alternating means one by one, and acute. These are 3A: asymmetrical, alternating, acute, anterior uveitis. So patient will have, other than, I can say, back involvement, you can see patient will also have UV involvement. Very, very important. So ankylosing spondylitis patient, generally these are a young patient, and mainly you will see males are more affected. And which males? Understand, it is seen in those males usually whose height is above 6 feet. So those who are taller than 6 feet, right? Then you can notice like these patients, they will have inflammation, which is like in deep lower back. Sometimes we'll see in the buttocks due to bilateral symmetrical ascending sacroiliitis. Then I can say these patients, if you see them, like whenever you see a patient, like it is having all the features that we see like rheumatoid arthritis. So they will be alternating pain. This is alternating pain, and along with this you will see patient will tell you like in the rheumatoid arthritis I told you there will be stiffness in the hand. Here you will see patient lying stiffness in the back. So there is morning stiffness. There is early morning back stiffness. So patient will tell you in the morning, I am having rigidity in my back. I cannot turn. It's very rigid, and this is lasting for more than 30 minutes. Then you ask what you will do, what he will do. So he will tell you like this will improve. This morning stiffness, it will improve with activity. So by evening it will improve. And just remember, it will also improve by taking hot shower. And this also question came in your exam. So this was the question of NEET PG 2022. So whenever patient is taking a hot shower, the stiffness will improve. So sometimes there is nocturnal awakening due to pain. It will improve with activity. And first of all, we have to rule out TB. Because TB, like TB spine, what we call spot spine, it will have similar manifestation. Then what they ask you what is most common complication. So there is risk of like C5, C6 fracture. So there is risk of C5, C6 vertebral fracture. So this is the fracture symbol. So patient will have more chance of fractures. Then there is like enthesitis. So basically it will involve like your tendons, like Achilles tendonitis. There is plantar fasciitis. Sometimes you will see like patient will have a costochondral inflammation, or I can say inflammation in manubrium sternal joint here. So they will feel symptoms of costochondritis. And whenever any patient who have costochondritis, it will mimic like pain that we see in MI patient. So he will have chest pain. So because of this, patient will develop MI like chest pain. So this is why like costochondritis is one of the differential diagnoses of angina. So how you will approach the patient? You can see X-ray. So first will be X-ray. So in X-ray what you will see bone ankylosis. That is what we call this bone fusion. Because of bone fusion or ankylosis, you can see the spine will look like a bamboo. We call this bamboo spine. Because of bamboo spine. Now it is not investigation of choice. Investigation of choice will be MRI. Now coming to interspinous ligament calcification. When you see calcification, a thick white line is seen. A thick white line is seen. This is what we call this dagger sign. This thick white line is what we call this dagger sign. Then sometimes you will see like apophyseal joint capsule calcification, and we see this joint capsule calcification. What we call this a trolley track sign. We call this a trolley track sign. So investigation of choice will be MRI. Because on MRI you will find sacroiliitis. Now coming to treatment. So in treatment what we can use NSAIDs, that painkillers. So I told you like we can use indomethacin or any other painkillers. So along with this what we need, so we can use indomethacin. indomethacin like Indocap, many brand names are available. Then you can use physiotherapy. Then we can use certain TNF inhibitors like etanercept, abitacept, and we can use IL-17 inhibitor. So what is the name of IL-17 inhibitor? It is secukinumab. Secukinumab. So these are the possible options that we can give in a patient of this. Then what they can ask you, they ask you the condition called DISH. What we call this? It is diffuse idiopathic skull hyperostosis. DISH. So DISH is diffuse idiopathic skull hyperostosis. It is something which affect elderly. And they ask you like patient will develop ligament calcification. So ligamentous calcification will give you an appearance like wax is flowing down from the candle. We call this flowing wax appearance. Or we call this flowing wax appearance. Then you can see like intervertebral disc space is preserved here. There is no sacroiliitis. Now let's talk about a type of arthritis which will have initially some sort of infection, like patient may have some STD, like some sexually transmitted disease, or I can say some respiratory tract infection, and even gastroenteritis. So 2 to 4 weeks before patient will have infection with Salmonella, Shigella, Yersinia, Chlamydia, Neisseria, then he will develop arthritis, right? And mainly remember the most common joint you will see here, most common will be knee joint. So actually B27 is classically associated, like Jaipur, I told you. Well, remember a patient will have some mucocutaneous manifestation. You can see oral ulcers. Then you can notice like patient will have a thickening of palms and soles. We call this Scleroderma blenorrhegica. Scleroderma blenorrhegica. Then some people what they will develop inflammation in the penis. We call this succinate balanitis. Succinate balanitis. And remember there will be inflammation in the fingers. There can be dactylitis. There will be dactylitis. And because of this dactylitis, understand these fingers, what we call them? We call them sausage digits. Such fingers are called sausage digits. Just remember, sausage digits means thick fingers. These are also seen in psoriatic arthritis. So they are also there in psoriatic arthritis. So just look at the screen. This is your Scleroderma blenorrhegica, and this is the balanitis that we see in the penis. So how we remember this Reiter syndrome? You can remember by mnemonic like can't see. The patient will have a classical triad. Can't see, can't pee, can't bend the knee, or you can say can't dance with me, or can't climb a tree. So for climbing, for dancing, what we need our joints. So there is arthritis. Can't see means patient cannot see, means conjunctivitis. Can't pee means urethritis. So conjunctivitis, urethritis, arthritis. So this is the triad of Reiter syndrome or reactive arthritis. Now let's talk about the disease which is very, very important, extremely important, and always carry 1 to 2 MCQ in exam. So this is your rheumatoid arthritis. It is most common multisystemic inflammatory autoimmune condition. Now what they ask you, suppose you are having a patient of rheumatoid arthritis, then what will be the finding you will see? So it will target your synovial joint. So it will initially cause synovitis. So there is synovitis, means inflammation of joint. Then slowly you will notice like there is abnormal granulation tissue formation. This abnormal granulation tissue formation is called pannus. So there is pannus formation. Then you can notice like there will be some erosion in the cartilage as well as in the bone. So you can see cartilage plus bone erosion. Cartilage plus bone erosion. Now it's a systemic disease. So you can see other than joint, skin, eyes, lungs, heart, blood vessels, all are involved. So what they ask you based on the progression. So we can divide this into very early, and late. So suppose very early means symptom develop in less than 3 months. So this is like a critical period. We call this the critical period is very early. It is like best for making diagnosis and treatment. It is like critical period. If you diagnose, critical period for DX means diagnosis, and for RX means treatment. Suppose what is a benefit here? Suppose if you diagnose this in this period, then you will see almost 100% recovery. So I can say this is like a best window period to prevent the further damage to joints. So it's best window. It is, I can say, best window to prevent joint damage. To prevent joint damage. So what is the recovery here? You can see, like, if you start DMARDs early. Previously you were starting with steroid, then say steroid, then DMARD. Now as soon as if we start DMARD early, here you will see early DMARDs, if you start, there is almost 100% recovery. So early DMARD if you start, then you will see it's very, very effective and there is almost 100% recovery. Second is what we call this early established. So previously it was very early, now early. In early established, you will notice like there is a sign of an inflammation. So you can notice acute synovial inflammation. Along with inflammation, you will notice like here, if you start the treatment, still it is very effective. You will not see 100% recovery, but still you will see 80 to 90% recovery. So treatment is still effective. Treatment will be still effective. But what happens sometime you will see when it is established very late. In case of late establishment, you will see like patient is now, it's been 1 to 2 years, he's already having some sort of deformity. We can see there is a progressive joint destruction. There is already some sort of progressive joint destruction. Means joints have already destroyed. So here understand this thing, that treatment response will be slightly lesser. You will see treatment response will reduce. And fourth is like suppose it's been more than 2 years, we call this chronic stabilized or stable RA. Stabilized form means now it's been more than 2 years. You can see joint damage, the deformity. Suppose if the person is having bending of the finger, this is now permanently reversible. So we will not see this is permanent means it's irreversible. It will not reverse. So joint damage will become irreversible. So what we can control? So why we start treatment? So starting treatment late, what is the role here? It will have a very limited benefit, right? It has limited benefit. But still, then why we start treatment? So, like suppose a person is having a bending of finger. He's having suppose swan neck deformity, or I can say bottonier deformity. This swan neck is bottonier. Now the point is, our goal is to prevent some extra articular complication, right? So here focus will shift to disability management. So now focus will shift to disability management. So this will be your goal. Okay, then what they ask you, suppose you are having a patient who is having rheumatoid arthritis. So we can divide this into 4 categories: very early, late, and chronic stabilized. Then suppose if you ask me about epidemiology, so what is most common age group? So you can see it is either affecting people in the age of 40 to 60 or sometime even older than this, means older than 60-year-old. So then they ask you what is female is to male ratio. So here female is to male ratio is 3:1. But remember, there are many conditions. Most autoimmune disease, they are commonly seen in females. So very few exceptions, like ankylosing spondylitis is the one which is commonly seen in males. The reason being, like, males are having a tall height. Females, they don't have height generally above 6 feet. So it's affecting those people whose height is above 6 feet. So ankylosing spondylitis is commonly seen in males. So what are the conditions which are commonly seen in females? And female is to male ratio will be 9:1. So here we have disease like Sjogren syndrome. So Sjogren syndrome is one which is 9 times more common in females. Then I can say SLE. If you ask me about drug-induced lupus means DLE. So that is something which is having equal prevalence. So drug-induced will be 1:1, male female 1:1. But normal SLE 9:1. Then other than this, remember, there is a vasculitis that is called, there is a type of myalgia called fibromyalgia. So it is something that is commonly seen where in females. Then you can see like a condition called PBC, primary biliary cholangitis, PBC. Then we have something called chronic fatigue syndrome. Chronic fatigue syndrome, it is something which is commonly seen in females. Then even like if you talk about temporal arthritis. Temporal arthritis is also something which is commonly seen in females. Even Takahashi is also slightly common in females. But some condition which will have 15 times more prevalence in females, that is what condition we call this as MCTD. MCTD is mixed connective tissue disorder. Clear? So these are conditions. So even Takayasu I can write here. So these are those conditions I can say which is commonly seen in females, and MCTD is something which is 15 times more common in females. Now, what are the factors contributing? So another thing, there are HLA DRB1 allele. What is HLA DR allele means DRB104. It is the key allele. Then we have 114 and 101. So they ask you there is a one thing which is protective. So which allele is protective? It is HLA DRB113. So this is something which is protective. Then what they ask you suppose if a person is having QKRRA mutation. This QKRRA, this is present in DRB114. This will increase risk by 5-fold. QKRRA. Again, this question never came, but they can ask in future. Now, what are non-HLA genes? So, non-HLA genes we have PADD4. This will encode for enzyme that is responsible for post-translation modification of arginine into citrulline. Then second is PTPN22. PTPN22 means it is another risk factor, and this once asked in INICET. PTPN22. What are some environmental risk factors? So just remember, the most important and most common environmental risk factor will be smoking, and just I want to write it here. Smoking will increase risk of both RA and OA, means both osteoarthritis as well as rheumatoid arthritis. So most important environmental risk factor will be, I can say, smoking. Then you can notice like it will increase the risk of extra-articular manifestation, especially which manifestation you can see like ILD. So understand this thing. When a person who is having rheumatoid arthritis, and if that person is smoking cigarettes, then that will increase the chance of ILD by 5-fold. So 5-time chance can be increased. Then you can see there is increase in PADD4 expression in hair-based tissue. This what it will do. It will promote citrullination. It is something which is promoting citrullination. It is promoting citrullination. Then another environmental risk factor is chronic periodontitis. So this periodontitis, the cause is being linked to a parasite. That is what we call this Porphyromonas. We call this as Porphyromonas gingivalis. And because of this, you will see there is increased abnormal protein citrullination. Then just remember, whenever a person who is having smoking associated ILD, this is seen in RA patient. So what are these smoking related interstitial lung disease? So first, what patient will develop? He will develop, it is called desquamative interstitial pneumonia. We call this as DIP. Right? Desquamative interstitial pneumonia. Then patient can develop, in smokers you will see they have chance of developing Langerhans cells histiocytosis. We call this Langerhans cells. Then remember, patient can develop respiratory. There is chance of respiratory bronchiolitis. Respiratory bronchiolitis. We call this respiratory bronchiolitis associated ILD. In short, we write like this, RBILD. Then patient can also develop rheumatoid arthritis related ILD. So what is the take home message here? Suppose any person who is smoker, they have chance of DIP, Langerhans cell disorder, respiratory bronchiolitis associated ILD, and RA associated or RA related ILD. Now what are protective factor? Mild alcohol consumption is protective. OCP in mild to moderate use is protective. Then just remember pregnancy. Why? Because pregnancy, understand, it will increase IL-10, it will have anti-inflammatory effects. So these are 3 protective factors for rheumatoid arthritis. Now what they ask you like how you'll make a diagnosis. So first is what we see like we have antibody. So we can do a test called RA factor. So now coming to what is rheumatoid factor. Rheumatoid factor is nothing, it is IgM against FC portion of IgG. It is IgM against IgG, we call this rheumatoid factor. So this is like a test which we can do in every patient. It is like a 100-200 rupees test, and just remember it is positive only in 70% of population, but it is cost effective test. So 70% population will have this RA factor, or we call this rheumatoid factor, but it is not a fully specific or sensitive test. So what we do NTCCP. So I can say this is what we call investigation of choice. So if you ask about specificity of this test will be 95%, right? And this is something I can say 95% means that is highly specific. So this is like used for early diagnosis, it's preclinical marker, and high titer will have more chance of extra-articular involvement. So suppose any person who is having high marker, so this is something, it's actually an antibody which I can say it is mostly specific to RA. So it is considered the most specific test or investigation of choice. Now coming to second type of antibody, what we call this anti-carb mylated peptide antibody. Now understand, the specificity is still under studying. We are still studying about these antibody. So it is something I can say it is less studied, and this is something which is associated with palindromic rheumatism. Moving to third, which we have discussed, IgM against FC portion of IgG. This is a rheumatoid factor. So you can see specificity is 75 to 80%. In some books you will see it's written 70%. But remember this rheumatoid factors, what they ask you in exam, whenever any patient who is having suppose high titer, of rheumatoid factor, this is directly proportional to disease activity. So more the titer of this means more severe disease. But remember it is less specific than NTCCP. Also just remember it can be positive. So it can be positive in other diseases like Sjogren syndrome. It can be positive in Sjogren syndrome. It can be positive in Cryoglobulinemia. It's even two-third cases, then polyarticular juvenile interstitial arthritis, then infective endocarditis, leprosy, PBC, some parasite infection, silicosis, sarcoidosis, severus, BC. It is not the best test because specificity is 70 to 80%, and this test is false positive in many conditions. Now what they ask you what are the articular manifestations. So what are the joint changes you can see? So first is you will notice there is atlantoaxial involvement. So this is generally due to involvement of C1, C2 vertebra. So they ask you most common type of cervical myelopathy. So most common cervical myelopathy means which cervical vertebra is involved? It is C1, C2. Or they can ask you which myelopathy is common, cervical, thoracic, lumbar, cervical, C1, C2. Then you can notice like there is radial deviation of wrist and ulnar division of MCPC. Radial division of wrist, right? Radial division of wrist here, and ulnar division of MCP. So this is what we call this zigzag deformity. It is called as zigzag deformity. Then they ask you like patient can develop a subluxation of MCP joint. There was a rupture of ulnar collateral ligament. When you see this ulnar collateral ligament is ruptured, it can lead to piano key deformity. Piano key deformity. Then sometimes we can see an hypermobile thumb. This thumb will be very, very mobile. You can see this hypermobile thumb. We call it Hitchhiker thumbs. But remember, this Hitchhiker thumb is something which is non-specific. You can see this Hitchhiker thumb in many other conditions. So where we can see Hitchhiker thumbs, understand this thing. It is like I can say abduction. So an abduction and hyperextension thumb. Abduction and hyperextension of thumb. Then we have two common deformity which they ask in exam, bottonier and swan neck. So just understand this thing. If you ask me what is swan neck, so swan neck is, look at me, flexion of flexion of DIP. This flexed and hyperextension of PIP. Is hyperextended, this is flexed. So flexion of DIP and hyperextension of PIP. So what we call this? We call this swan neck. And when we see what is bottonaire, so understand bottonaire is exact opposite. Means here you will see in bottonaire you will see flexion of PIP here and hyperextension of DIP. So this will be your bottonaire. Bottonaire, swan neck. This is bottonaire, swan neck. Swan neck, bottonaire. Bottonaire, swan neck. So bottonaire is something which is, I can say, flexion of PIP and I can say hyperextension of DIP. So this is about your bottonaire. Then some people understand, some people you can see this a total complete destruction. This a complete destruction of joint. What we call this opera glass hand. So complete destruction is called opera glass hand deformity. So these are some deformity which we see in a patient of rheumatoid arthritis. Okay guys, now let's talk about what are extra articular manifestation that we see in a patient of rheumatoid arthritis. So just remember, most common will be rheumatoid nodules. Most common extra articular manifestation, it will be your rheumatoid nodules. Now these nodules basically we see on the extensor surface. Then there are other organ involvement. So you can see there will be CNS involvement. So I told you like there is involvement of C1, C2 cervical vertebra. So there is C1, C2 myelopathy. There is C1, C2 myelopathy that we see in a patient. Now coming to ocular manifestation. So ocular, like patient can develop many things. But remember, most common will be dry eyes. This dry eyes, what we call this keratoconjunctivitis sicca. Keratoconjunctivitis sicca. Then patient can develop episcleritis. You can also see scleritis. So there can be episcleritis, scleritis. Then there will be thinning of sclera. We call this scleromalacia. So this is like a beautiful diagram given in Harrison. So in this diagram, you will see all the extra articular manifestation. So let's start seeing this drawing. First, you can see ocular manifestation, keratoconjunctivitis. We call this keratoconjunctivitis sicca. Then you can notice patient can develop scleritis, episcleritis, right? Then oral cavity, you will see xerostomia, periodontitis. So in simple language, I can say, you can see here, dry eyes, dry mouth, right? So it is actually leading to your secondary Sjogren syndrome. And just remember, most common cause of secondary Sjogren syndrome. Primary Sjogren means Sjogren itself is a disease. The most common cause of secondary Sjogren syndrome will be rheumatoid arthritis. Then in lungs, you can see pleural effusion, you can see nodules, you can see ILD. Patient can develop pneumonia. Then carditis, most common will be pericarditis. It can lead to heart failure. And just remember, these heart involvement, it will ultimately lead to like early onset heart failure, and this is the cause of death. So cause of death generally occur because of cardiac involvement. Then patient can have kidney involvement. There will be MGN. So which type of nephropathy patient can develop? Membranoglomerulonephritis. Patient can develop secondary amyloidosis. Now understand, secondary amyloidosis we also call this AA amyloidosis. Primary amyloidosis we call this AL amyloidosis. Then secondary amyloidosis, just remember, primary amyloidosis we see AL type, that is seen in multiple myeloma. Secondary where we see in chronic inflammation. So most common cause of secondary amyloidosis is also rheumatoid arthritis. But in India, TB is more common. So they ask you this type of question, most common cause of secondary amyloidosis in the world, it is RA. In India, it is TB. So secondary amyloidosis in India, it is TB. In the world, it is rheumatoid arthritis. Then patient can develop like a decrease in testosterone that can lead to infertility, erectile dysfunction. Then these are rheumatoid nodule. And what are these nodules? This is what I am telling you on extensor surface. These are some of the, I can say, most common extra articular manifestation. So most common extra articular manifestation will be these nodules. Then some people can develop pyoderma gangrenosum. There is osteoporosis. Patient can also develop vasculitis. Then this is like a patient will complain of neck pain because of involvement of C1, C2 vertebra. Then patient can develop anemia. So which anemia? It is AOCD, anemia of coronary disease. Some people can develop neutropenia, splenomegaly. We call this Felty syndrome, and there is chance of leukemia and lymphoma. Right now, one question which they ask in exam is something that I'll discuss subsequently. So they ask you like what type of anemia you will see. See, so rheumatoid arthritis patient. Now see, when I talk about India, so in India you will see iron deficiency is very common. So already people like Indian females, they have iron deficiency, so they can develop ID. Then in rheumatoid arthritis, understand this thing. What we give? It's a chronic inflammation. In chronic inflammation, we will see AOCD. AOCD means anemia of coronary disease. And third thing, what they ask you like when we give methotrexate to patient, methotrexate is most common use DMARD. DMARD means disease modifying anti-rheumatoid drugs. So when we give methotrexate, and along with this, if you are not giving folic acid, like methotrexate, we start in dose of 7.5 to 15 mg once in a week. It's not even ODBD, once in a week. So when we give 7.5 to 15 mg once in a week, and if we are not giving folic acid with this, patient will develop folic acid deficiency, and folic acid deficiency is macrocytic anemia. So understand this thing now. Iron deficiency is microcytic. Chronic inflammation anemia is initially microcytic, but later on and mostly it convert into normocytic. And methotrexate, if you are giving to patient, it will lead to folic acid deficiency, that is macrocytic. So here you will see all different types of anemia, all types. Like we had a patient for rheumatoid arthritis, so because of confusion in brand names, so I have written a tablet called Folitrax. Folitrax is methotrexate. There's one more tablet called Folvite. Folvite is folic acid. So what I did, I wrote Folitrax 15 mg once in a week, and Folvite, the Folvite is folic acid, 5 mg tablet at once OD. But what patient did? She took folic acid once in a week and methotrexate daily. So after 1 month when she came, what happened? She developed anemia. That is your macrocytic anemia. So understand this thing. The question which came in one of the exam is what is most common anemia? So most common anemia in rheumatoid arthritis out of these will be normocytic, normochromic. So rheumatoid arthritis patient can develop all type of anemia, but most common will be normocytic, normochromic. Okay, now let's understand. What is this Felty syndrome? So Felty syndrome, you will see. In Felty syndrome, you will see like patient can develop nodules, there will be deformities, rheumatoid factor is positive, HLA will be DRB104. What is the name of antibodies? So you will find antibodies against citrullinated histones. So antibodies against citrullinated histones. Now what are the symptoms that you will see? So whenever a person is developing Felty syndrome, understand this thing, patient will develop rheumatoid arthritis. There will be splenomegaly, and patient can develop neutropenia. And patient can develop neutropenia. And if you compare this, sometimes they ask you like all R component, or sometimes they give you clinical case. If you compare this with one more syndrome called Kaplan syndrome. So what is Kaplan syndrome? Understand this thing. Here patient, you will see patient will develop rheumatoid arthritis. You will see patient will develop rheumatoid arthritis. And along with this, there will be Cole-Worker pneumoconiosis. Cole-Worker pneumoconiosis. But remember, most common lung manifestation is pleuritis. This pleuritis later on can cause pleural effusion. So most common lung finding will be pleuritis, and patient can also develop ILD. ILD means interstitial lung disease. Now what they ask you like a patient can develop a Cole-Worker pneumoconiosis is seen in, you will see there is active synovitis and rheumatoid factor is positive. Now coming to kidney. In kidney, what I told you, patient can develop secondary amyloidosis. Secondary amyloidosis, and secondary amyloidosis, what I told you, it is which type? AA type. And patient can develop MGN. So they ask you which type of glomerulonephritis is seen. It is membranous glomerulonephritis. They also call this membranous nephropathy. You can call membranous glomerulonephritis or membranous nephropathy. Then patient will have accelerated atherosclerosis. What is the meaning of this thing? Atherosclerosis, which was supposed to develop, like suppose in a patient who in the age of 40, it will develop in the age of 30. So early atherosclerosis means patient will develop early ASCVD. What is ASCVD? Early atherosclerosis cardiovascular disease, and ultimately patient will develop early MI. And this is the thing which will cause death of patient. So they ask you why people develop, why people die. It is because of early onset atherosclerosis. Now let's talk about management part. So management part, understand this thing, we can use NSAID. So NSAID will provide symptomatic pain relief. Then we can use DMARDs. So nowadays we don't wait to start DMARD. Start DMARD at the earliest. If there is no improvement coming, then what we introduce drugs called biological drugs, or we call them biologics. Now coming to different types of DMARD. So what are the types of DMARD that you should know? So most common used DMARD worldwide, this is methotrexate. Again, what I told you, we give this in a dose of 7.5 to 15 mg. This is the initiating starting dose, once in a week. Then if there is no improvement coming, we can add other DMARDs like leflunomide. So these two drugs, understand, these are considered category X drug. Category X drug means these are the drugs which are avoided in pregnancy because they can affect the upcoming baby. Third drug in this list is sulfasalazine. So what we can use? We can use sulfasalazine. Sulfasalazine, it can cause male infertility. And lastly, suppose if a patient is having arthritic pain, not responding to NSAID, then what we add? We add a drug called hydroxychloroquine. Hydroxychloroquine in short we call HCQ, or sometimes called as HCQS. So this is, suppose if I ask you what is drug of choice. So drug of choice, if you have to choose, then choose the answer methotrexate. But if they ask you what are the drug of choice in pregnancy we prefer to give hydroxychloroquine because methotrexate can cause neural tube defect. Clear? So it is avoided in pregnancy. Suppose when we give methotrexate, it should be supplemented with which drug? Just remember, always add folic acid. And folic acid, that dose that you study in gynecology is 400 microgram. That is prophylactic dose. Here, the therapeutic dose that we use is 5 mg OD. Clear? So here we will not use that 400 microgram. Here we will use 5 milligram OD. Okay, now coming to no response coming from suppose DMARD. Then what we use biological agent. So what are these biological agents? So here you can remember a mnemonic, INCAGE. INCAGE means it is infliximab. So these are the drugs basically acting on anti-TNF or acting on TNF. Then what we have certolizumab. Then we have a drug called adalimumab. Golimumab, and etanercept. So another this thing, this etanercept, it will act on fusion protein. So basically, it is acting on decoy receptor for TNF and immunoglobulin. So this is like, these are the drugs that which are available. But now understand this thing, like every time we'll see some new type of drugs. So what are the new oral drugs we have? So some oral molecules now we have in the market. So they are effective in those people, suppose, because the problem with these biologic is these all drugs which I have mentioned here, they are very, very expensive. So they are expensive, very expensive. So now we use some new drugs, like we have a drug called JAK1, JAK3 inhibitor. So JAK1, JAK3 inhibitor, the drug is tafactinib. So this is available in oral tablet form, tafactinib tablet form. JAK1 and 2 inhibitor, this is what we call this drug baricitinib. Then there's a new drug that is also having action in multiple places, that is called iguratimod. Iguratimod. So it is a new drug which we have for rheumatoid arthritis. So this will have its action on multiple places. Like it can act as DMARD. It will also act on TNF. So these are the possible options. Okay, now try to understand this thing. What they ask you what are other biologics drugs. So we can use anti-CD20 antibody. Anti-CD20 antibody that we use, this is what we call rituximab. So same rituximab which we use in treatment of non-Hodgkin lymphoma. Then we have anti-IL-1. So interleukin-1 receptor antibody, that anti-IL-1, this is your drug called anakinra. Just remember, IL-1 is causing fever, so anakinra we can also use in those patients with Kawasaki disease where fever is not responding. Then we have anti-IL-6. This question came in exam, and this drug we have used a lot in COVID. It is tocilizumab. We call this tocilizumab. Then there is one more, we call it sarilumab. Sarilumab. Okay, now coming to a drug which is acting on CTLA4, or I can say CTLA4 FC immunoglobulin fusion molecule. This molecule that is sometimes used and it's having good efficacy, we call this abatacept. So these are the possible options which we use, which we give in a patient of rheumatoid arthritis. Now let's summarize the treatment part. You can see HCQS. This is hydroxychloroquine tablet. So it's available in 200 mg, 400 mg. So we can use like 200 to 400 mg daily, right? Then you can see this hydroxychloroquine. This is a drug. So basically, why we give this? It is controlling arthritis component. So it is also given in SLE arthritis. In SLE, we can also use this drug for photosensitivity. So this can lead to irreversible retinal damage. It can cause cardiotoxicity. It can sometimes cause blood sclerosis. Then these are some rare side effects. Then they ask you, like, whenever you start hydroxychloroquine, what things you should keep in mind. Remember, when we start, it can lead to retinal damage. So there should be eye examination if person is above 40. Right? Or I advise, like, before starting this, we should send the patient to ophthalmologist once. So how we monitor this? Toxicity we can monitor by fundoscopy and visual field testing every 12 months. Okay, moving to next drug, like it's available with the brand name of FAS, and different brands are available, sulfasalazine, SAS. So 500 mg BD is the dose, initial dose. Then we can take it to 1000 to 1500 mg daily. It can cause granulocytopenia and hemolytic anemia. Then remember, it is affecting your RBCs, WBCs. So we'll always do a CBC. So CBC every 2 to 4 months before starting this drug. Now third is methotrexate. So very, very toxic drug, right? So you can see 10 to 25 mg. But in Indian scenario, why? It is like given in Harrison, but in Indian population, we start the dose with 7.5 mg. Why? Tell me why. Because understand this thing, if you see, like, if you check hemoglobin of 10 Indian females, you will find out of these 10, 9 will have hemoglobin value less than 12. 12 is the cutoff range for WHO. So Indian females are already anemic. So in Indians, we start the dose with 7.5 mg. Then we can use folic acid. Like it is like 500 mg to 1 mg per day to reduce toxicity. So methotrexate can cause hepatotoxicity. It can lead to bone marrow suppression. It can cause infection. It is a category X in pregnancy, so we avoid in pregnancy. So we will always check CBC, LFT. Then remember, it can also reactivate many infection. So methotrexate is very, very important. And just remember, it is causing myelosuppression, and very, very important, it can cause your B9 or folic acid deficiency because it is dihydrofolate reductase inhibitor. Okay, moving to next drug, it's leflunomide. So we give it a dose of 10 to 20 mg per day. Leflunomide. So it can also cause myelosuppression. It is also category X, so we will not give this to patient those who are pregnant. Then remember, it can cause alopecia in some people. So again, it is causing myelosuppression, so we will do a CBC LFT. Then we have biologics. These are drugs like infliximab. Okay, so problem with infliximab, understand. First problem is it is a biologic drug. So this is a drug which can reactivate many infection in the body. Especially it can reactivate hepatitis B, it can reactivate TB. So it can reactivate infection. So it is written here, it can reactivate latent TB and it can reactivate hepatitis. Suppose you had hepatitis B career state, hepatitis C career state, that can be reactivated. Then it can produce serious infusion reaction. Sometimes some people can develop infusion reaction. So before this, like PPD skin testing is advised. Then we have etanercept. Again, this is like injectable drug. So you can see it can have injection site reaction. Toxicities are same as infliximab. So for all these, you will see, for all these, they can cause infusion reaction. They can cause injection site reaction. They can reactivate many infections. So we should always do PPD skin testing. Clear? And always keep on monitoring the injection site. Then remember, these are the drugs that we use, and like rituximab, anakinra, abatacept. What are these? These are all acting on TNF. These are biologics. Basically, these are biologics drugs. Right. Okay, guys. So now we talk about SLE, systemic lupus erythematosus. This is, I can say, one short question in exam. So what they ask you about the details? So they ask you SLE is something which is very commonly seen in females. So like previously I told you, like there are certain diseases which are commonly seen in females like Sjogren syndrome, SLE, none of this. Then if you ask me about childhood SLE is something which will have 100% renal involvement. 100% renal involvement you will see there in childhood SLE. Then we have post-menopausal SLE. So this is generally, I can say, like a milder form. It is a milder form. And remember here, kidneys are not such involved. So there will be renal sparing. So you can see here renal sparing. Now they ask you like, what is most common cause of death? So understand this thing. Suppose if most common cause of death, like in first 5 years, just remember the most common cause of death will be infection. And sometime like after infection, I will say it is due to kidney involvement. Means we call this SLE nephritis, or you can call lupus nephritis. But if they ask you like after 5 to 10 years, or even later in older people, what is most common cause of death? It will be accelerated atherosclerosis. It is accelerated atherosclerosis, and it can ultimately lead to MI. So patient can develop myocardial infarction, means early onset atherosclerosis, so early onset MI. Okay, then they ask you like male SLE. So we see SLEs generally commonly seen in females, but sometimes you will see SLE can also be seen in males. So they ask you which males. So generally these males, understand this thing. SLE is commonly seen in those males who have Klinefelter syndrome. So there is some pathology has been linked to Klinefelter syndrome, because Klinefelter syndrome karyotype will be XXY. So this is something which is severe and it will have a poor prognosis. Now coming to family history, SLE will always have a strong family history. Now let's talk about what are the risk factors. So first we have genetic risk factor. So it can occur because of certain HLA. So HLA which are important here will be HLA-DR2, and we have HLA-DR3. Then remember it can occur because of complement deficiency like C2, C4 deficiency. Then they ask you what are non-HLA indications. So remember it is due to C1q inhibitor deficiency, or I can say C1q. This is C1q. So most common complement deficiency is, we write like the C1q. This is most common complement deficiency which is seen in SLE. Okay? Or I can say we call this most common, or even we call this early complement deficiency. Then some pathogenesis is associated with a gene that is located at chromosome 3. This gene is called as TREX gene. And TREX gene, remember, it is located on 3rd chromosome. And I told you there is some association on X chromosome. This is why remember, increased risk where in females, because females, what they have 2X, and more risk where in Klinefelter syndrome. Why Klinefelter? Because they have XXY, right? Then there are certain environmental risk factors. What are environmental risk factors? First is like estrogen containing OCPs. So estrogen containing OCPs can increase the risk. Then I can say Epstein-Barr virus, very important. And this question came in INICT. So Epstein-Barr virus infection can trigger the attack of SLE. Then remember UVB rays, ultraviolet B rays, and this is a common reason for development of photosensitivity. Now let's talk about what are the features of SLE. So what is the pathophysiology? So you can see there are multiple pathophysiological processes which take part cumulatively together in SLE. So first out of these, first will be this a defective clearance. Means you will see in SLE patient apoptotic bodies are not fully clear. So apoptotic bodies are not clear. So what it will cause? It will cause next neutrophilic extracellular trap. We call this netosis or neutrophilic extracellular trap. So it can lead to entrapment of neutrophils. Then second, I can say there is defect in innate immune system. So when you see like there is innate immune system, means since birth immunity is defective, it can lead to like plasmacytoid dendritic cells, and what they will secrete a chemical. This is called as interferon alpha. Then you can see sometime T cell activation. This T cell activation by Th2 cells. You can see interleukin 4 production. It can cause interleukin 4 production, and that 4 production will lead to B cell activation. So there is activation of both T and B cell. Now see, what is the role of B cell? So role of B cell, I can say is B cell will produce autoantibodies. Once B cells are activated, now what they will do, they will produce autoantibodies, and you will see formation of immune complex. And whenever we see immune complex formation, it is which type of hypersensitivity? Yes, come on, it is type 3 hypersensitivity. So they ask you, understand this thing. SLE per se, SLE is which type of hypersensitivity? So understand this thing. In SLE, we have two things. Organ manifestation of SLE. Organ, or I can say tissue manifestation. This is type 3 because in organs you will see immune complex deposition. But antibodies which are in the blood, these are freely moving. So blood manifestation is type 2. So SLE is considered both type 2 and type 3. If both are given in the option, then choose type 3. Because mostly it's a disease that's affecting your organs. Then you can see like there's sites of immune complex. So where this immune complex will deposit, it can deposit in vessels. So when it deposits in vessels, what we get? We get vasculitis. When it deposits in synovium, we get synovitis. And when this is affecting your glomerulus, so what we'll get? We'll get glomerulonephritis. We will get glomerulonephritis. So these are the findings we see in a patient of. These are the pathophysiological findings, and the result we see in SLE. Now they ask you like what will be the symptom. So symptoms you can notice like patient will develop some constitutional symptoms. So you will see there will be constitutional symptom. So these are most striking feature. Then there can be fever, there will be fatigue, there will be weight loss. Then they ask you what are other manifestations you can see, like patient will develop chronic inflammatory polyarthritis. So it's a multisystemic disease. So you can see multiple system will be affected. Then there is bilateral symmetrical small joint of upper limb affected. So what do we call this? We call this which type of arthritis? It is non-erosive type. You can see bilateral symmetrical non-erosive type of arthritis. Then some people understand this thing. They will have deformity due to laxity of ligament. This is what we call this Jacquard's arthropathy. So understand what I want to explain here is normally arthritis is non-deforming. But here you can say deformity. So what it is? This is your Jacquard's arthropathy. It is seen when SLE is associated with some other disease like RA. So understand this thing. So normally arthritis is non-erosive, symmetric and non-deforming. It can become deforming. When SLE is associated with RA. And now what we call this? We call this Jacquard's arthropathy. Then they ask you, suppose mucocutaneous, or I can say cutaneous lupus. We call this cutaneous lupus erythematosus or CLE. So we have different types of CLE, like we can have acute type, we can have subacute type, we can have chronic type. So We have total 3 types. So starting with the first one, acute type. So in acute type, what you will notice? In acute type, you will notice like there will be localized rash. And this rash, if you see carefully, if you see this rash is not involving your nasolabial fold. These folds are not involved. So this localized rash was what we call this. We call this butterfly rash. We call this butterfly rash. Then patient sometimes can develop generalized rash, and in some cases it can lead to TEN. TEN means toxic epidermal necrolysis. Then what do I ask you? Suppose when you see this rash, this is like we call this malar rash. Malar rash. And this rash means whenever this patient will go into sun, this rash will increase. So it will be having photosensitivity. You can see patient will have photosensitivity. Then remember, this is like patient can develop non-scarring. It will not produce any scar. So you can see non-scarring scaling, which is highly erythematous. And these patients understand, just remember, SL is something where patient can develop oral ulcers. In acute phase, you can see oral ulcers. Normally, ulcers are painful, but here these ulcers are usually painless. So patient can develop painless ulcers. And what I told you, what is not involved, it will spare your nasolabial folds. So nasolabial folds are not involved. But the good thing is, like if you see like any no finding in this is pre-malignant. So there is no non-pre-malignant lesion. All these are non-pre-malignant lesions. Second type, what we call is subacute type. The subacute type, we also call this like annular type. Now understand this thing. Here we also call this psoriasiform subacute cutaneous lupus erythematosus. So in this type, you will see photosensitivity and again non-scarring. So photosensitivity in fact will be more than acute type, but there is no scar. But just remember, it spare. This is something which will spare mid-facial region. It will spare mid-facial region. So mid-facial region is not involved. The antibody you can find now is anti-Rho or SSA or anti-La. Anti-Rho I told you previously in Sjogren's syndrome, as well as is also there in neonatal SLE. Then here you will see there is less risk of nephritis and vasculitis. And this type, I can say this subacute type will have genetic association with HLA-DR3. HLA-DR3. After this, what we have third type. Third type is called chronic type. So understand this thing. This chronic cutaneous lupus, we call it CCLE, or sometimes called disseminated lupus erythematosus. In this chronic type, you will see most common lesion. The type of rash, we call this discoid rash. We call this as discoid rash. And if you see like here, you will see like 5% of these patients, they will develop SLE. And 20% of SLE, understand, 20% of SLE patient, they will have discoid rash. So it is like what we call this 5-20 rule. Means 5% of DLE patient, they develop into SLE. And 20% of SLE patient, they will have discoid rash. This discoid rash, they ask you what are the common sites. So common site, it will be in the face, neck, scalp area. So common site will be face. Then you can see in the neck. You can see in the scalp area. You can see like a deep circular erythematous lesion. There is dermal atrophy. You can see follicular plugs. You can see scarring alopecia. This scarring alopecia, you will notice, they also call this cicatrizing or scarring alopecia. We call this carpet track sign. Carpet track sign. We call this as carpet track sign. Then understand this thing. Here you will have some risk of pre-malignancy, and that is like it can lead to there is increased risk of SCC, means squamous cell carcinoma. So there is chance like patient can develop squamous cell carcinoma. So these are 3 types: acute type, subacute type, and chronic type. Now what they ask you, like patient can have CNS involvement. So first try to understand this thing. In CNS we have 2 things. We have neurological involvement and psychological involvement. Understand this thing. If I tell you like CNS involvement, the patient will develop cognitive dysfunction, It is because of antibody called anti-glutamate antibody. This anti-glutamate antibody is sometimes also called as anti-neuronal antibody. Anti-glutamate or anti-neuronal. And some people, they will develop psychotic symptoms like depression, sometimes hallucination. This P for psychosis, P for anti-P. So antibody name is P. So what we call this? We call this P antibody, or I can say anti-ribosomal P antibody. Anti-ribosomal P antibody. So just understand this thing. Psychotic symptom, P for pagal. Psychosis. CNS means neurological symptom, neurological, and for an anti-neuronal. Then remember, here you will notice like axial skeleton is spared. There is no entrapment neuropathy, like sometimes we see a cubital tunnel, carpal tunnel, we see in Hashimoto's and rheumatoid. You will not see this here. A small fiber neuropathy can occur. Then we talk about ocular involvement. So there can be secondary Sjogren syndrome. However, remember, in secondary Sjogren syndrome, the most common cause for this was rheumatoid arthritis. So they ask you, when patient develop a secondary Sjogren, this is actually most common ocular issue. It is most common ocular issue. Uveitis is absent. Here you will not see uveitis. Now coming to pulmonary involvement. So most common will be pleuritis. So pleuritis was also most common finding in rheumatoid arthritis. So most common is pleuritis. Later on, this pleuritis can convert into pleural effusion. So it can convert into pleural effusion. So patient can develop like a lymphocytic exudate. Here we will see normal glucose, right? And it can increase the risk of malignancy related effusion. Then what they ask you like patient can develop diffuse alveolar hemorrhage. So whenever any patient, this question once came in NEET PG, any patient of SLE, if they are having diffuse hemorrhage in the alveoli, this is something like it's a marker of high disease activity. So it is, I can say it is a marker of severe disease. So it is a marker of high disease activity. It's a marker of high disease activity. Then what else you will notice? You can see some cardiac involvement. So understand this thing. Most common cardiac involvement will be pericarditis. So most common is pericarditis. But what they ask in MCQ, like patient can develop Libman-Sack endocarditis, right? So this pericarditis patient will develop, but it is generally without tamponade. Patient can develop valvular heart disease. So they ask you what is most common valvular heart disease. So remember, most common will be MR. So patient can develop mitral regurgitation. Then there can be Libman-Sack endocarditis. In Libman-Sack endocarditis, what they ask you, you will see vegetation. Suppose these are the valve leaflet. These are the valve leaflet. So you can find some tiny vegetations. So when you find these tiny vegetations where these are seen on lower surface of wall, a few on upper surface of wall. So these are called vegetations. So understand this thing. In Libman-Sack, you will see these vegetations are sterile. So I can say non-bacterial. We call them non-bacterial, or we call them sterile vegetation. Whenever vegetations are sterile, remember, this will not increase the risk of any emboli formation. Then you can see these vegetation, these are formed on lower surface or under surface. But remember, lower surface are more than upper surface. So more on lower. Suppose, like I can say, I can keep more money in my pant, because in pant jeans we have 4 pockets. So we also call this vegetation on valve pocket. Means lower more than upper. Vegetation where on valve pockets. So this is about your Libman-Sack endocarditis. Then they ask you about hematological manifestation. So understand this thing. In SLE, what type of RBC changes or WBC changes you can see? The first, patient can develop AOCD. It is a chronic inflammation. So patient can develop anemia of chronic disease. Then patient can develop warm type of AIH. So we have 2 type of AIH, cold type and warm type. So here you can see warm type of AIH. Then remember, a patient can develop low WBC count, so they can develop leukopenia. Even some people they can develop secondary ITP. Secondary ITP means their platelet count will reduce, means they can develop thrombocytopenia. Thrombocytopenia, why they will develop? Because antibodies will be against RBC, so that will cause AHA. Antibody will be against RBC. When antibodies will be against WBCs, they will get low WBC count. And when you have antibodies against platelet, then you will see thrombocytopenia. So this thrombocytopenia, basically when you develop antibodies against platelet, what we call this? We call this secondary ITP. ITP is secondary immune thrombocytopenic purpura. In primary type, you will get antibodies against where GP2B3A. Now coming to what else you can notice, like a patient can have increased risk of lymphoma. And which lymphoma? You will see there is increased risk of DLBCL. DLBCL is diffuse large B-cell lymphoma. Coming to vascular manifestation, you can see like there is increased risk of acute coronary syndrome. So basically this will occur generally after 5 to 10 years. It will occur after 5 to 10 years of disease progression. 5 to 10 years of disease progression, patient will develop increased risk of acute coronary syndrome. Then patient can develop vasculitis. Now they ask you which type of vasculitis you will see. So vasculitis is what we call this leukocytoclastic angiitis. Leukocytoclastic angiitis. And sometimes you can see like some dangerous vasculitis. So initially it's involving just skin, but later on it can involve your GIT. So we can get gastrointestinal vasculitis. And some people understand they can have involvement of brain vessels. It can lead to CNS vasculitis. So these are some dangerous form of vasculitis we can see in a patient of SLE. Okay, now a patient can also develop some kidney changes. So what we call this like a lupus nephritis. Okay guys, now let's talk about lupus nephritis. In lupus nephritis, what we see, there are total 6 types. Out of this, just remember, most common type diagnosed, it is type 4. So understand this thing, in class 1 to 3 or type 1 to 3, I can say patient will not have much symptom. In type 5 and 6, so let's see, in type 5 and 6, there is one more class 6. You will see very advanced feature, means you will see almost all CKD features. So now it is converting into CKD. So what they ask you in exam is like, what is most common type diagnosed? So most common type diagnosed, because in class 1 to 3, patient will not come to hospital or clinic, right? And in I can say class 5 and 6, now it is CKD. CKD, or I can say advanced type of disease. So here now we will do nothing in making diagnosis. What we have to do, we have 2 options, either dialysis or kidney transplant. So what are these all 5 types? So understand this thing. Class 1 is something we call this as minimal mesangial type. So class 1, what we call this minimal mesangial type. So here you will see minimal proliferation. So there is no major finding. You can see in microscopy sometimes hematoxylin in bodies, and as such there is no treatment also needed. So in this there is no treatment required. So no treatment is needed in type 1. So type 2, what we call this mesangial proliferative type, means we call this mesangial type. So here you will see proliferation where in the mesangium, mesangioproliferative. So let me just first write the different types. So we have minimal mesangial type, we have class 2 at mesangial type, class 3 is called focal. Class 4 is something what we call this as DPGN, or we call this diffuse type, diffuse proliferative glomerulonephritis. Now understand this thing, we use the term diffuse when you see more than 50% of glomeruli involved, and we use the term focal when you see less than 50% glomeruli are involved. So when more than 50%, we call this diffuse. So most common type diagnosed, this will be class 4. So most common type of lupus nephritis will be type 4. This class 5 is called membranous type. So class 5, it is called membranous type. and class 6 is very advanced type. So here you will get all the features of CKD. So these are total 6 types. So now understand this thing. So I told you in class 1 what we are doing nothing. In class 2, remember in class 2 we have to give, I can say some treatment is needed, but again when it's not producing much symptoms, so in class 1, 2, 3 there is no as such treatment needed. So we have to treat simple SLE, but for as per lupus nephritis you will not give, I can say, such a treatment. Now coming to, because patients not coming, so no treatment required in these, and mostly actually I can say these 3 types they are not diagnosed. Now coming to class 4. So class 4 is what we call this DPGN. DPGN stands for diffuse proliferative glomerulonephritis. So in class 4 you will see many important features. So first is what you will find in microscopy. You will find this hematoxylin body, and they ask you like what you will find in immunofluorescence. So normally what we see in glomerulonephritis, you will see sometimes antigen is depositing, sometimes some antibodies, sometimes you will see mesangial cell proliferation, sometimes you will see something is accumulating in basement membrane. Here you will see everything: antigen, antibody, immune complex, C1q, C3, IgG, everything. So this is what we call this as full house effect. Full house effect. What is the meaning of full house effect here? The meaning of full house effect is ABCD. ABCD is what? Anybody can deposit. So here you will see anything can deposit. So anybody can deposit. In type 4 we call this full house effect. Now answer this thing. It is diffuse type, so you will see more than 50% glomeruli are involved. Then you can see it is most common type and also most dangerous type. So they ask you what is most common type of lupus nephritis is type 4. So in type 4 what we need to do? So here understand the treatment plan will be different. So here we will do aggressive, we will start aggressive immunosuppressant drug. So aggressive immunotherapy. So this is the treatment plan where in, I can say, type 4. Okay, now coming to class 5. So class 5 is something which is a stage, which is I can say impending CKD, or patient will have all the features like, I can say, initial stage of CKD. So in this case what we say, we call this, I can say, membranous type. In this you will see patient will have some risk of CKD, or I can say it is initial stage of CKD. So here we need to treat this by mycophenolate mofetil and calcineurin inhibitors. So basically we treat this with MMF and CNI. CNI is calcineurin inhibitors. Now understand this thing. This is something, class 5 is something that is refractory to steroid. And in class 6, understand, in class 6 what option we are left now is dialysis or transplant. Am I clear? So there is a low risk, I can say there is some risk of CKD here in class 5. Actually it is ultimately, it's a progressive disease. So class 5 will convert into class 6. So these are the types. Now coming to diagnostic part. So how we make a diagnosis of SLE? For this what we need SLIC criteria. Now what is this SLIC? SLIC is Systemic Lupus International Collaboration Criteria. So just remember what are the different criteria which I'm talking right now. Like SLIC criteria we use for SLE. We have ACR Uric criteria that we use in rheumatoid arthritis. Then we have Casper criteria. I told you where Casper criteria we are discussing psoriatic arthritis. So just remember these 3 criteria. SLIC criteria, this is for SLE. Then I can say Casper criteria. This criteria was for psoriatic arthritis. Then I can say ACR. ACR is American Colleagues of Rheumatology. League. ACR Euler, European League Against Rheumatism. This criteria is for rheumatoid arthritis. So just remember these are 3 criteria that sometimes they ask in exam. So SLIC criteria, Casper criteria, ACR Euler criteria. So how we make a diagnosis by SLIC criteria? Remember we need 4 or more than 4 features. In this 4 or more than 4 features, we need 1 clinical and 1 laboratory criteria. Or I can say patient should have a biopsy proven lupus nephritis with positive ANA or anti-dsDNA. So ANA is, I can say, most sensitive antibody, and dsDNA is something which is a specific antibody. Then suppose, remember this question they ask in exam, suppose a patient is having chronic disease anemia. It is not a part of diagnostic criteria. So they ask you all are part of criteria. So let's see this criteria, what we have. Okay, first try to understand these are a total 6 type. So we see class 1 that is minimal proliferative type, or we call it minimal mesangial proliferative. Then we have class 2 that is called mesangial proliferative. We have class 3 that is focal. Class 4 is diffuse. This is most common type. And class 5 is membranous, and class 6 will be advanced type, where you will see all the CKD features. So this is about your histopath classification that we see in lupus nephritis. And just remember all the findings which we find, like sometimes you can find wire loop lesion. So the wire loop lesion, full house effect, this you will find in class 4. Now, what is full house effect? Let's talk about full house effect. So understand this thing. Suppose full house effect, I told you it is IgG, IgM, IgA, C1, Q, C3, anything will deposit. So means it is nothing. It is, you will see a lot of deposit. So when you see a lot of deposit, or I can say anybody can deposit, this is what we call full house effect. And they ask you type 4 SLE. What is the name of type 4 SLE? It is called as DPGN. DPGN means diffuse proliferative glomerulonephritis. Then in this DPGN, what is most common finding? So this is again a pathology question which they ask in exam. You can see wire loop lesion. So this is something which we find in a patient of lupus nephritis. Clear? Okay, let us now look at this criteria. This is ACR Euler criteria. A second criteria what we have is Silic criteria. So these are two criteria that we use for SLE. ACR Euler is also used for rheumatoid arthritis. So let's understand this thing. So what features here we have? We have like clinical criteria like fever. You can see non-scarring alopecia, oral ulcers, then discoid lupus, sometimes cutaneous lupus, synovitis or tenderness at least 2 joint. Then some CNS symptom like delirium, psychosis, seizures. I told you that CNS symptom, they are because of antineural antibody. Then serositis like pleuritis or pericarditis. Then hematological domain. But remember, in hematological domain, what is not? Anemia of chronic disease. That's not a criteria. Then kidney features like proteinuria or any class of lupus whether patient is having. Now coming to immunological criteria. So what we have here? Here we have antiphospholipid antibody domain. So any one of these antibody which we see in Apla syndrome. So these are basically antibody we see here in Apla syndrome. Antiphospholipid antibody syndrome. So we have anticardiolipin, lupus anticoagulant, right? Anti-beta 2 glycoprotein. So these are the antibody what we see in Apla syndrome. Then you can see complement activity will be low C3, low C4. Then antibody titer, that is anti-dsDNA and anti-Smith. So here just understand this thing. Most specific antibody will be anti-Smith. But if they ask you which is specific as well as sensitive, this is specific antibody as well as sensitive antibody, and remember it is also correlating to disease activity. This antibody, anti-dsDNA, it is directly proportional to disease activity. Means more the titer of this antibody, severe will be the disease. So this is your anti-dsDNA. So this is why like most clinician, even I used to do this test in my practice, because from this anti-dsDNA I will get an idea like how severe is the disease. Is it clear? So these are suppose I can say sometimes they ask an exam like classification criteria are not diagnostic criteria. So all patient of SLE, like suppose they're classified as having SLE, they have ANA titer more than 1:80. It is called entry criteria. But normally what we say 1:80 for SLE, otherwise what we say 1:160. Then patient must have at least more than 10 points to be classified as SLE. Then items can be counted for classification if there is no more likely cause. So highest criteria in a given domain that will be counting, and SLE classification required point from at least one clinical domain. So there is one clinical and one lab finding that we need. So we need one from this list and at least one from this list. This is how we make a diagnosis. Now coming to treatment part of SLE, how we are going to treat. So let's understand this thing. So first we need to decide like SLE, is it life threatening or not life threatening? So answer this thing. If it is not life threatening, quality of life is acceptable, then we give symptomatic treatment, symptomatic or conservative. But if quality of life is not acceptable, then what we give? We give low dose steroid. And sometimes we can think of a drug that is called belimumab. If it is life threatening, then we double the dose of steroid. We will give high dose glucocorticoid, right? And sometimes we can add a second agent like second steroid sparing agent like any other immunosuppressant like calcineurin inhibitor or MMF, mycophenolate mofetil or cyclophosphamide. Then what we see after response, cyclophosphamide we give in maintenance with mycophenolate or azathioprine. Suppose no response is coming, then we will add belimumab, rituximab or calcineurin inhibitor. and slowly taper the dose of all agents. If response is coming, then we taper the dose. If not coming, then what we do, we add other agent. So what dose tapering is needed? Understand this once again. If it is not life threatening, what we do, just we give a low dose steroid. Simple. If it is life threatening, then we give high dose steroid plus some other agents like MMFs and cyclophosphamide initially. Then suppose if response is coming, then we slowly taper the dose, especially dose of steroid. If no response is coming, then we add drugs like belimumab, rituximab, calcineurin inhibitor. So what they ask you in exam, they ask you like high dose inhibitor. High dose inhibitor means what is the dose? So high dose means it is like 1 to 2 milligram per kg per day. 1 to 2 milligram per kg per day. So this is given when it is life threatening. Otherwise, what we do, conservative management. Conservative management, what we give in this, what we give HCQS and other symptomatic treatment. Then there's a drug that is called anifrolumab. So they ask you what is this drug. So remember, this is something which is like inhibiting all the of first type of interferon. So it is a type 1 interferon inhibitor. Type 1 interferon inhibitor, that is anifrolumab. And low dose steroid means we will give steroid in a dose of 0.3 to 0.5 mg per kg per day. This is indicated when it is not life threatening. When it is not life threatening, in this we give dose of 0.3 to 0.5 mg per kg per day. Now understand this thing. They ask you what are different antibodies and what is their significance. So first, most specific antibody. So most specific antibody, I told you it is anti-Smith. If you have to choose one, just remember anti-Smith is slightly more specific than anti-dsDNA. So if you have to choose one, then answer is anti-Smith. So specificity, the answer will be anti-Smith. Then what they ask you which antibody correlate with disease activity. So one I told you that was anti-dsDNA. Anti-dsDNA, actually it is the best antibody to do in practice. It is sensitive, it is specific, it is correlating with disease activity. But there is something which is even more telling you about the flare, the exaggeration of symptom. This antibody is called as anti-C1q. So this antibody is called as anti-C1q. Now they ask you what is most sensitive antibody. So most sensitive antibody will be ANA. ANA is anti-nuclear antibody. Okay, they ask you now drug-induced lupus. So drug-induced lupus, it is generally seen with SHIP drugs. So what are the SHIP drugs? So it is sulfur drugs like sulfasalazine, hydralazine, isoniazid, and with P we have procainamide and also I can say phenytoin. So these are SHIP drugs. So understand this thing, these are SHIP drugs in pharmacology also. They ask you a question, these are those drugs which are metabolized by a process. Can you tell me the name of that process? This process is called as acetylation. They are metabolized by acetylation, and antibody which we will find in the drug-induced lupus, this antibody is called antihistones. Antihistones. And just remember, this drug-induced actually is something. This is something where male is to female ratio will be 1:1. So normally what I told you actually is affecting more in females, but here it will be 1:1. Okay, now coming to neonatal lupus. So understand, in neonatal lupus I told you antibody anti-Rho. Anti-Rho we also call this SSA, means Sjogren syndrome. It is also seen in Sjogren syndrome. So they ask you like neonatal lupus, if it is present in pregnancy, the patient will develop neonatal lupus. Now what is the finding which we see in a baby? I told you this thing before. So this baby in neonatal SLE, it will not present with butterfly rash. It will have complete heart block. So neonatal SLE, remember, it will present with complete heart block. Complete heart block means third degree AV block. We call this third degree AV block. Okay, now coming to antibody which we find in CNS. Suppose if you ask me CNS, what I told you, we call this antibody anti-glutamate. Anti-glutamate. This anti-glutamate is also called as, the other name for this will be anti-neuronal. Anti-neuronal. Then they ask you, like, suppose what is most common CNS findings. So patient can develop a lot of findings. They can develop dementia, they can develop delirium, but what is most common? So understand this thing. Most common, I can say, CNS finding, that will be cognitive dysfunction, means patient will have defective cognition. So most common CNS finding will be cognitive dysfunction. Cognitive dysfunction. Okay, then they ask you psychosis or depression or mania or bipolar, means psychotic, P for P. So this antibody is anti-ribosomal P. So which antibody will cause anti-ribosomal P antibody? So this is the antibody which is causing psychosis in SLE. Then what they ask you, suppose a patient who is having diffuse scleroderma. So understand this thing. So we have two versions of scleroderma. One is called diffuse and second is called superficial form. So superficial form is called Crest syndrome. This diffuse form we also call systemic sclerosis. So in diffuse you will find an antibody called anti-topoisomerase. Anti-topoisomerase. The commercial name for this will be anti-SCL70. Anti-SCL70. When we have a mixed connective tissue disorder, we call this MCTD. It is something which is 15 times more common in female. So in MCTD, what you will see, the antibody name is called anti-U1 ribonucleoprotein, anti-U1 RNP. Now coming to dermatositis, which antibodies? So here we are writing all the antibodies, what we see in generally in rheumatological condition. So dermatomyositis, polymyositis, understand this thing. Here the antibody what we find in both, in dermatomyositis as well as polymyositis. This I'm writing here, dermatomyositis and polymyositis. So antibody which we find is called as anti-Jo1. Anti-Jo1. Then what we have, suppose there is a condition called anti-synthetase syndrome. So understand this thing. In anti-synthetase syndrome also you will find anti-Jo1. So just try to understand this thing. In dermatomyositis, polymyositis, you will find anti-Jo1. But if I talk about only dermatomyositis, here you will find an antibody called anti-Mi2. So just remember, anti-Mi2 is something which we see only in dermatomyositis. So this is important point. So I'm writing here. This anti-Mi2 is seen only in dermatomyositis. So understand this once again. Both dermatomyositis, polymyositis as well as anti-synthetase syndrome, all these three. So suppose this is first, this is second, this is third. All will have anti-Jo1. But dermatomyositis will also have one more antibody called anti-Mi2. Now coming to Crest syndrome, this is like limited form of scleroderma. So here antibody you will find is called anti-centromere. So here antibody that we will find is anti-centromere. And now Sjogren's syndrome we have discussed a lot of times. So here antibody what we call this anti-Rho. Anti-Rho is also called as SSA. And we have anti-La. Anti-La is called as SSB. So these are the antibody in Sjogren's syndrome. So this is about the different type of antibody in rheumatological condition. Now sometime what they ask you like autoantibodies immunofluorescence pattern. So we have a different pattern of immunofluorescence that we see in antibodies. So first is what we see like different staining patterns. So first type of pattern is what we call this homogeneous pattern. So nowadays like this type of topic is trending in exam. So they ask you like this homogeneous pattern where we see this anti-DSDNA and anti-stone. Now coming to anti-DSDNA and anti-stone, where you will find these. So these are seen where in SLE patient. Where else you will see this? You will see this where in a patient of MCTD. And this is also seen something in drug-induced lupus. In drug-induced lupus. So understand this thing. Homogeneous pattern you will see where in SLE mixed. So sometimes they can ask you the name of disease. Sometimes they can ask you which antibody will have homogeneous pattern. So remember anti-DSDNA and anti-stone. Second is what we have. We call this speckled pattern. So understand this now. Speckled pattern. So speckled pattern you will see where in anti-Smith, anti-RNP. RNP is same ribonucleoprotein. Anti-SSA, SSB. SSA means Sjogren's syndrome, that is anti-Rho. SSA also called as anti-Rho. SSB also called as anti-La. So understand this thing. This is something. So anti-Smith where we see in SLE. So you will find this speckled pattern in SLE. Anti-Row, where we see anti-Row we see in Sjogren syndrome. So Sjogren syndrome. Then remember, sometime you will see this type of speckled pattern also in a patient of poly and dermatomyositis. Polymyositis and dermatomyositis. And lastly, what I can say, it is also seen where? In scleroderma. In scleroderma. Third pattern, understand this third pattern is what we call this nucleolar pattern. So nuclear pattern, understand, you will see where in anti-RNA antibody, anti-PMSCL70. So this is something like even this question came in exam, just I'm highlighting this. So understand this thing, what is anti-PMSCL antibody? This came in last 2023 in 8 PG. So anti-PMSCL means anti-PM means polymyositis. So whenever patient will have feature of polymyositis, SCL means scleroderma. So it was a clinical case came in exam, like patients having feature of polymyositis as well as scleroderma. So what is the name of antibody? It is PMSCL. Polymyositis, SCL is scleroderma. First alphabet of scleroderma. So where you will see this? You will see this where? In diffuse scleroderma. In diffuse scleroderma, also called as systemic sclerosis. So diffuse scleroderma. Then we can see this where? We can see this in a patient like of polymyositis. You can see this in a patient of polymyositis. So just mark my word, this question came NEET PG 2023, like a patient is having feature of both scleroderma as well as polymyositis, which antibody you will find it as anti-PMSCL. Then there is a condition, like you can also see this in a condition called overlap syndrome. Now what is overlap syndrome? When you find feature of two or more autoimmune disease, we call this overlap syndrome. Overlap syndrome. Clear? Then you can also see this where in like localized version of scleroderma, mainly you will find centromeric antibody, but here you will find in diffuse form. So let us see this. Next pattern, what we see. Next, like sometimes they ask you image based question. So this is, you can see homogeneous pattern. Then you can notice this is what we call this as, this pattern is called speckled pattern. You can see a cleft in the between like this. This type of pattern is what we call this speckled pattern. Then you can see this is what we call this like bigger cells, we call this nuclear pattern. Next is anti-centromere or centromere pattern. The centromere pattern you will see in anti-dsDNA. So anti-dsDNA, where we see anti-dsDNA is an antibody that is seen in SLE patient. And one more thing, remember, the centromeric pattern is very, very classical for a limited, or I can say a superficial form of scleroderma, that is called Crest syndrome. So it is seen there in Crest syndrome, and we call this limited scleroderma Crest syndrome, and it is also seen where? In a patient of SLE. So SLE can have all this pattern. Then what we have? Peripheral pattern. So peripheral pattern sometimes you will see an anti-Smith antibody. And lastly what we can see like a cytoplasmic pattern. So this is something that we see in anti-Jo1 antibody. Anti-Jo1 I told you where? In dermatomyositis, in polymyositis, and anti-synthetase syndrome. Anti-synthetase syndrome. Now let's talk about other antibodies, means what are other antibodies in different places that we see. So first is Hashimoto's. In Hashimoto's, what we find anti-TPO antibodies. So this anti-TPO is anti-thyroid peroxidase antibody. So this is something which we see in a patient of Hashimoto's thyroiditis. Coming to next. So we have antibodies against TSH receptor. So here I'll write a few more names like anti-TRA. Anti-TRA is thyroid receptor antibody. Then we have like LETS. LETS is long-acting thyroid receptor antibody, right? And TSI. TSI is thyroid stimulating immunoglobulin. So anti-TRA, LETS, TSI, these are the antibodies where we see, these are the antibodies we see in a patient of Graves' disease. In a patient of Graves' disease. So just remember, Hashimoto is most common cause of hypothyroidism and Graves' disease is most common cause of hyperthyroidism. Then we have an antibody called LKM. LKM stands for liver kidney microsomal. This anti-LKM antibody, understand, this can also be seen in a patient of hepatitis C, but mainly in LKM, what you have to remember autoimmune hepatitis. Autoimmune hepatitis. Here you will find which antibody? You will find anti-LKM1. So they ask you sometime like what are the pathological findings which we see in a patient of autoimmune hepatitis. In short, we write like this, AIH.
So you will find like lymphoplasmacytic infiltrate, lymphoplasmacytic infiltrate, and along with this you will see like there is a fibrosis between, I can say, portal tract and hepatocyte. We call this interface hepatitis. Then you can find like one cell eat up another cell. So one cell within cell appearance. Cell within cell appearance, what we call? We call this emperipolysis. Emperipolysis. So this is like INICET pathology question. Emperipolysis is the feature of autoimmune hepatitis. Okay, now moving to AMA. AMA is anti-mitochondrial antibody. So anti-mitochondrial antibody, it is something which we see in PBC. What is PBC? PBC is primary biliary cholangitis. This PBC, like, it's a disease where you will see like mainly intrahepatic granulomatous inflammation of bile duct. If you see both intra and extra, that is called PSC. PSC is primary sclerosing cholangitis. So they ask you like this PBC is a condition which is commonly seen in females, and when these females they have, so you will see generally it is associated with other autoimmune disease. So it is associated with Sjogren syndrome. It is associated with Sjogren syndrome. It can be distal RTA. You can see patient can have xanthoma, osteopenia, pruritus. Now what they ask you, suppose a patient who is having anti-mitochondrial antibody, you will find in pathology you will find autoimmune process. So autoimmune inflammation. So there is autoimmune inflammatory destruction of intrahepatic bile duct, right? So when you see like intrahepatic bile duct destruction, we call this as florid duct lesion. It is called as florid duct lesion. Then what we have? We have atypical ANCA or atypical P-ANCA. This is something which we see in a patient of PSC. PSC is primary sclerosing cholangitis. So here you will see both intra as well as extra. So just remember, PBC is something which is only intra. Here you will see intra as well as extra, and main damage you will see in extra, mainly extra. Now they ask you like what you will find in biopsy. In PSC, in biopsy you will find like there is onion skin appearance. In biopsy you will find onion skinning. But more important is they ask you like for diagnosis of PBC, what we do is we do biopsy. But for PSC what we can do is we can do ERCP or MRCP. So in what they ask you one more thing, like in PSC, in MRCP, what is the finding we see? We call this as beaded appearance. Beaded appearance, or we sometimes call this pearls on string appearance. Pearls on string appearance. Okay, now let's talk about P-ANCA. So P-ANCA we have discussed in vasculitis. So which vasculitis will have P-ANCA? So just remember PCM. PCM means P-ANCA. It is seen in Churg-Strauss syndrome. Churg-Strauss syndrome, and I can say microscopic polyangiitis. So PCM, paracetamol, P-ANCA. Churg-Strauss syndrome, microscopic polyangiitis. C-ANCA. So I don't like the name of Wegener, so I will write it Wegener's. So it is seen in Wegener's for two reasons. Wegener's will have C-ANCA, and drug of choice for Wegener's, C for cyclophosphamide. So just remember the C-ANCA and cyclophosphamide. We also call this granulomatous polyangiitis. Now coming to ASCA. ASCA, I told you where. ASCA we have discussed in GIT. It is seen in Crohn's disease. And one more thing, remember, ASCA is sometimes also seen in Behcet syndrome. Can you tell me any other antibody in Behcet syndrome? Come on. Any other? Yes. Any other antibody? Okay. Choose from this. What is left now? Rheumatoid factor. What is rheumatoid factor? Rheumatoid factor is IgM against IgG. So it is nothing. It is IgM against FC portion of IgG. FC portion of IgG. And where we will find this? It is something which we find in rheumatoid arthritis. Then we have anti-endothelial antibody. So endothelium is disrupted. It is something that we see in a patient of Kawasaki disease. It is something that we see in a patient of Kawasaki disease. Now what is left for Behcet? Alpha, anti-alpha analysis is left. So this is something which we see in Behcet syndrome. Just remember, Behcet can also have ASCA as well as antinolase. So these are some other antibody which we see in other conditions. Now let's talk about a disease which is considered diagnosis of exclusion. It is considered diagnosis of exclusion. What is the meaning of this line? So the diagnosis of this we will make at the end, after ruling out everything, because this is something which is not having any specific test. So we make diagnosis late, and it is something which is very commonly seen in black female, or I can say African female. This is sarcoidosis. So if you see, like sarcoidosis generally affect individuals who are young adults, and these are mostly above 18 years. So male and females are equally affected because it's not an autoimmune condition. So there are multiple pathogens that we see here. They ask you like what you will find in histology. So the finding that we see is called non-caseating granuloma. Non-caseating granuloma. Now what is the meaning of this thing? Remember, caseating granuloma is something that we see in TB. Here you will find non-caseating. Right? So caseating, actually what happens in sarcoidosis, 2/3 is non-caseating and 1/3 is caseating. Sarcoidosis you will see both. So 2/3 is non-caseating, so that's why what we call this non-caseating. But in TB it is caseating. So we call like this: TB caseating, sarcoidosis non-caseating. Clear? But actually in sarcoidosis, 2/3 is non-caseating, 1/3 is caseating. Now understand this thing. You will see some immune products, means you can see there is increase in T lymphocytes. So T lymphocytes will increase within granuloma. And but they will be more in the granuloma, but in the periphery you will see lymphopenia. Lymphocytes will be less, so that's why there is increased chance of infection. Then they ask you like what is the disease progression. So first is, some people what they have, you can see spontaneous resolution. So in most cases you will see spontaneous resolution, but sometime understand this thing, almost in 25% cases it can convert into chronic disease, and in 5% cases it can lead to mortality, it can lead to death. What does they ask you? We have different type of sarcoidosis. So first is what we have, acute sarcoidosis. So here we have two syndrome. First is called Lofgren syndrome, second is Herford syndrome, or we call this Herford-Waldenstrom syndrome. So understand this thing, Lofgren syndrome patient will have arthritis. So there will be arthritis. There will be hilar lymphadenopathy. You can see hilar lymphadenopathy means hilar lymph nodes are affected. Then there will be a swelling on the tibial area. That is what we call this erythema nodosum. We call this erythema nodosum. Erythema nodosum. So they sometimes ask you clinical case like what it is Lofgren syndrome. Similar to this what we have Herford syndrome. So understand this thing, in Herford syndrome what you will notice patient will have, I can say, acute bilateral symmetrical anterior uveitis. Symmetrical anterior uveitis. So patient will have uveitis. Then there is parotitis. Parotitis means inflammation of parotid gland. Then there is seventh nerve palsy, but the unique feature is here the seventh nerve palsy you will see that will be bilateral. So there will be bilateral seventh cranial nerve palsy. And some people they have fever. So when they have fever, so sometime previously like it was also called as ovioparotid fever. So fever is plus minus. So most common finding that we see is bilateral seventh nerve palsy. So they ask you bilateral seventh nerve palsy where we see in sarcoidosis. Just remember this bilateral palsy we can also see in a patient of Guillain-Barré syndrome. Now understand this thing. Suppose they ask you like a patient who is having in heart in X-ray what you will find. So in X-ray you will find these three lymph nodes involvement. So what are these three lymph node involvement? So if I say this 1, 2 and 3, just focus on this. When you see this first lymph node, this is which lymph node? Then if you see first, let me say 2 and 3. Let's come to 2 and 3. So 2 and 3 they are close to each other. This 2 and 3 what we call right and left hilar. So 2 will be your which right hilar lymph node, right? 3 will be your left hilar lymph node, and this 1 will be your right paratracheal lymph node. Right paratracheal lymph node. So understand this thing, right hilar, left hilar, right paratracheal lymph node, these together what we call this Garland sign. It is called as Garland sign, or sometimes it is called as 1, 2, 3 sign. 1, 2, 3 sign. So we can see right and left hilar and right paratracheal lymph nodes. So this is something which I need to write here, but I have written on top. Clear? Okay, now understand this thing. You can see like patient will have arthritis, and this arthritis is something which will have insidious onset, right? Or I can say acute onset. There is bilateral painful or type of arthritis, or I can say tenosynovitis. Then you will notice like these patients, sarcoidosis patient, they will also have CNS involvement. So you can see 7th nerve, that is bilateral palsy. Some people, they will develop bilateral anterior uveitis. Then this is what I was talking about is erythema nodosum. Now coming to erythema nodosum. In rheumatic fever, the erythema that we talk about, that erythema is called as erythema marginatum. So erythema nodosum, is it for sarcoidosis only? No, it's a broad term. You can find this in sarcoidosis, you can find this in a patient of Crohn's disease, you can find this in ulcerative colitis, you can find this after side effect of many drugs. So it is a non-specific term. So what is erythema nodosum? Remember 3 P's means it is painful, it is close to tibia means peritibial area, and it is like patient having pigmentation, and it is papular, right? So just remember this is what we see without pigmentation. So you can see redness here. So painful, just remember painful, peritibial and papular. Now what they ask you, what about the prognosis? Because this erythema nodosum, you can see it's a component of your Lofgren syndrome, and if you see bilateral facial nerve palsy, that's a component of Hereford syndrome. So when they talk about prognosis, in I can say Lofgren syndrome, the prognosis is relatively better. So relatively good prognosis. Why? Because erythema nodosum is not a dangerous condition, right? Even if you see other findings like hilar lymphadenopathy is not a dangerous thing. Arthritis you can relieve by giving steroid, painkillers, by giving HCQS. But remember, this is something where you can see bilateral facial nerve palsy, which can sometimes lead to permanent damage. So they ask you like what is the HLA we see? So HLA that we see here is HLA DRB103. DRB103. Okay, now coming to lab data. So lab data means what they ask you, what is increase in sarcoidosis. So what are the things which will increase? So first thing, just remember there is increase in activity of angiotensin converting enzyme ACE. Then what is increased? You can see calcium is increased. So calcium will increase. So because understand there is granuloma. So this granuloma can synthesize vitamin D. So patient will have vitamin D, can increase the calcium. There is hypercalcemia. Then you will notice there is increased level of ALP. Alkaline phosphatase will increase. And I can say this is also a question. This came in exam. What is most common? Question was like this. Most common LFT derangement that we see in sarcoidosis. So most common liver function test finding in sarcoidosis will be increase in ALP. Then you can notice that there is increase in action of IL-2 receptor, elevated IL-2 receptor. So these are the findings which we see in a patient of sarcoidosis. Then you can see like what about CBC? In CBC you will find lymphopenia. And because of lymphopenia, remember, patient will have increased risk of infection. Then what they ask you like if you do bronchoalveolar lavage. So in bronchoalveolar lavage, you will find CD4:CD8 ratio. So normally this ratio is 2:1, but here this ratio will increase. And how much it will increase? It can be like 5:1. So CD4:CD8 ratio, it will be increased in bronchoalveolar lavage. Just remember this ratio, it is decreased where? In HIV. In HIV it becomes 1:2. So they ask you sometime question, reversal of CD4:CD8 ratio. What is normal ratio? So normal it is 2:1. In sarcoidosis 5:1. In HIV 1:2. So in HIV what we see, you can see reversal of CD4:CD8 ratio, that is seen where? In HIV. Then there is a very very old test which nowadays we don't use. We call this QUEAM test. So QUEAM test, it is an obsolete test, now we don't use, but sometimes they ask you question. Now coming to chronic sarcoidosis. In chronic sarcoidosis they ask you like what is most common organ. So most common organ, it is lungs. After lungs, After lungs, you can see it is involving your skin. Then remember, it can also affect your eyes. In eye, they ask you like what is the involvement. So in eyes, you can see patient will have pan-uveitis, and this pan-uveitis can complicate to form retinal vasculitis. It can complicate to form retinal vasculitis. Then you can see this like a type of rash. So if I zoom this rash, you can see this is looking like an SLE rash, but if you see, this is more depressed rash. And then remember, this rash is also involving your nasolabial fold. So this is what we call, this is not SLE butterfly rash, because SLE rash will not involve nasolabial fold. This is what we call this lupus pernio. So what is lupus pernio? It is a maculopapular or sometimes nodular type of rash. So maculopapular or nodular lesion, right, which sometimes mimic like SLE rash. Now when they ask you lung involvement, in lung what you can see it can cause ILD. That is actually a common cause of death. So patient can have like upper lobe ILD. Upper lobe ILD is seen. This upper lobe ILD, understand this thing, it will have a non-specific like interstitial pneumonitis like pattern, NSIP pattern. Then you can see bronchovascular bundle thickening. Sometimes you will see small airway or endobronchial obstruction, but there is no paravertebral mass or aortitis in sarcoidosis. So what we do is we do a scoring system. That scoring system is called as SCADing scoring system. So now understand this thing. This is basically an X-ray based classification of progression of disease. So we have total 4 stages of disease. So this is stage 1. So what you will find in stage 1, understand? In stage 1 you will find just bilateral hilar lymphadenopathy, that's it. Bilateral hilar lymphadenopathy. When it comes to stage 2, you will see lymphadenopathy, and along with this you can see lung infiltrate. So lymphadenopathy, so see, here you will find lymphadenopathy, here you will find lymphadenopathy plus infiltrate, both. In stage 3, you will see infiltrate will increase, means you will find only infiltrate. And stage 4 is like advanced form. So what we call this? We call this diffuse. Diffuse means you can see a lot of fibrosis. So these are called SCADing staging system that we see in a patient of sarcoidosis. Now in biopsy, what you will find? In histopathology, what you will find in sarcoidosis, understand this thing. So when you do biopsy, in biopsy you will find non-cacheating granuloma. And I told you actually this is 2/3 is non-cacheating. Then they ask you like epithelioid cells. These are actually the most important cells. Epithelioid cells are the main cells which form granuloma. It will have a special type of nucleus we call slipper shaped nucleus. Then you can find 2 different types of inclusion bodies. So first is what we call this asteroid body. And second, which they ask like it's a body due to calcium concretion. This is very, very important, which they ask in exam. We call this Schaumann bodies. We call this as Schaumann bodies. So we have asteroid body, and what we have Schaumann bodies. So these are 2 bodies that we see. So this is your Schaumann bodies which we see. This is, you can see a non-cacheating granuloma, and here what we see these bodies are called asteroid bodies. Lastly, what they ask you, what about gallium scan? Understand. So in gallium scan you will notice like there is increase in uptake. So uptake will be more in parotid as well as lacrimal gland. So uptake you will see where? In parotid and lacrimal gland. And this is something what we see, what we call this like it look like panda. So we call this panda sign, or there is one more called lambda sign. So panda sign we see with parotid, and lambda we see with hilar lymphadenopathies. We call this panda sign. So panda sign is basically parotid and lacrimal gland uptake will increase, and lambda is something that we see with hilar gland, clear, hilar lymphadenopathy. Okay, now understand. In sarcoidosis, now what they ask you, what are head to toe manifestation? In head to toe manifestation, let's talk from CNS. So in CNS, I told you like patient will develop bilateral facial nerve palsy. So you can see patient can develop bilateral lower motor neuron seventh cranial nerve palsy. Seventh means facial. So this is a part of ear-pod syndrome we have discussed. Then patient can also develop transverse myelitis. There can be central diabetes insipidus, and you can notice a leptomeningeal enhancement. Now coming to eye. So in eye, remember anterior, posterior, or I can say in simple language, it can affect any compartment of eye. It can affect any compartment of eye. Then they ask you salivary gland. So you can notice again a part of Herford syndrome, that was parotitis. Then that's why sometimes we call this uveo-parotid fever, means uvea is involved. So there can be parotid swelling. Then they ask you like what is the cardiac manifestation. So patient can develop DCMP, and patient can also develop restrictive cardiomyopathy. Both can occur. Then there will be conduction block. Moving to I can say some vascular manifestation. So you can notice patient can develop like immune complex mediated vasculitis. There will be immune complex mediated small vessel vasculitis. Small vessel means generally it will affect small vessel. Coming to joint. So in joint, what you can notice, like in joint, simple, like patient can develop arthritis. So there will be arthritis of joint. And in bone, you can notice sometime a bony cyst. Sometime you can notice bony erosions. Now they ask you about liver. So in liver, what you can notice, like suppose patient of sarcoidosis, I told you like ALP will increase in patient. So ALP is increased, it's a common LFT finding that we see. Then why this ALP is increased? Because there's some sort of cholestasis. ALP is a marker of cholestasis. So there is intrahepatic cholestasis. Intrahepatic cholestasis. Okay, now moving to kidney. So in kidney, patient can develop AKI. There is chance of AKI. This AKI means acute kidney injury. It can occur due to hypercalcemia, because I told you like granulomas can synthesize vitamin D, and that can increase your calcium level. Then patient can also develop CKD due to tubulointerstitial nephritis. Then patient can have bone marrow involvement. There is pancytopenia, lymphopenia, this splenomegaly. Now, how you will manage this patient? So what are the things that we do? So in management, what we do endobronchial ultrasound and transbronchial biopsy. And this is, I can say, this is the investigation of choice. So investigation of choice is biopsy, means transbronchial biopsy plus ultrasound, means ultrasound and guided biopsy. Then we can do PET scan. Why we do PET scan? So PET scan we do here because we want to know the extent of disease. So to know the localization, or I can say extent of disease, localization of disease activity, or I can say active disease, localization of active disease and extent of disease. Means suppose maybe patient is coming to you with only skin manifestation, but in PET scan we can see some changes in the lungs, some changes in the liver. Coming to first line. So first line treatment in this condition is always steroid. So we start steroid, and just remember, most patient, they will respond good. The only difficulty come in making diagnosis. Treatment part is simple, because diagnosis is very complicated, because first we have to rule out all other cause. Then suppose steroids are not working, then what we can use? We can use MTX. MTX is your methotrexate. We can use azathioprine. We can use methotrexate, and we can use HCQS. HCQS is hydroxychloroquine. And third line agent, last option what we have TNF inhibitors. So we can use TNF inhibitors like we have discussed in rheumatoid arthritis. So this was about sarcoidosis, which they ask routinely in exam. Now what they ask you, suppose you are having a patient of scleroderma. So what are the findings that we see in scleroderma? So again, this is a beautiful image of Harrison. You can see all the question in exam they ask you from this thing only. So let's start with oral cavity. So first finding, you will notice patient will have xerostomia. Xerostomia means it can cause secondary Sjogren syndrome. So secondary Sjogren syndrome, remember, most common cause I told you, that was rheumatoid arthritis. Then sometimes there will be like mucocutaneous telangiectasia. But one more significant finding which you will notice is there is small opening of mouth. We call this a decrease or diminish aperture of mouth. Decrease aperture of mouth means patient will have microstomia, a small mouth opening. But again, this is seen only in advanced cases. Then patient can have GERD, gastroesophageal reflux disease. There can be GAVE. GAVE is gastric antral vascular ectasia. We also call this watermelon stomach. There can be Barrett. There can be gastroparesis. Then in lower GI tract, you will see a decreased motility, sometimes back to lower growth, sometimes pseudo obstruction. Coming to lungs, patient can develop ILD. There can be pulmonary artery hypertension. Now this lung involvement, understand, it can lead to respiratory failure. And respiratory failure, this will become the cause of death. So you can see this table, this diagram is very beautifully given. It's answering everything. Then there can be carditis, there can be diastolic dysfunction, cardiomyopathy, arrhythmia. In I can say cardiomyopathy, patient can develop both DCMP as well as RCMP here. Then there can be renal involvement. So what is actually happening is there is action of a mediator. This mediator is called TGF beta. This will cause fibrosis in your lungs as well as kidney. So this because of fibrosis in renal artery, patient can develop a very high BP. So you can see patient will develop renovascular hypertension, and this is what we call this renovascular hypertension is called scleroderma renal crisis. Then you can notice in the skin some induration, calcium will precipitate, we call this calcinosis cutis. You can see telangiectasias, and there can be Raynaud phenomena. One more thing is you will see in the corner of digit, you can see initially ulcers. We call this digital ischemic ulcers. Digital ischemic ulcers, and sometimes what happens, you will see gangrene formation here. When you see gangrene formation here, then automatically you will see it will destroy the bone. We call this acro-osteolysis. Means acral part of bone is broken. So these are the findings that we see in a patient of scleroderma. And just remember, when it comes to skin, in some people in very advanced cases, skin will become very tight. And this tight skin is what we call this leather-like skin. So you can see this question also came in exam, leather-like skin we see in a patient of scleroderma. Now understand? So what will be the risk factor that we see? So what are environmental risk factors? So how patient can develop attack of scleroderma? So that is something like a patient is exposed to silica. So silicosis can be a risk factor. Or suppose patient is taking certain drugs like we have an anti-tumor antibiotic, we call this bleomycin. Or patient is taking pentajocin. Pentajocin is used very commonly in labor room. Or I can say exposure to PVC, polyvinyl chloride, or I can say patient is taking tryptophan containing amino acid. So you can see sometime like patients taking amino acid. So these are like things. So question this came in exam like which things or which drug and factor can cause scleroderma like illness. So they can cause either scleroderma like illness or they can trigger scleroderma. Now coming to genetic risk factors, so some people also have genetic risk. Then they ask you what is the pathogenesis. You can see first thing will be endothelial injury. Then it will lead to vasculopathy. Vasculopathy means there is vessels problem, some problem in the vessels. It can lead to thrombosis, hypoxia, fibrosis. And I told you fibrosis is always because of which mediator? TGF beta. Then you can see about inflammation marker. So ESR, CRP, it can be normal, it can be decreased, or even like suppose in advanced cases, it can also be increased. So we have a total, I can say 3 types. So we call this a diffuse type. So in diffuse type, you will see like anywhere you will find skin lesion. You can see skin lesion anywhere. Anywhere. Then it's called limited type. Limited type you will find lesion where in the face or in the distal part of limbs. Means distal upper and lower limbs. And in this type you will not see any skin involvement. Now they ask you like what are the features and manifestations. So in features manifestation, first thing you will notice patient will have Raynaud phenomena. So what is Raynaud phenomena? Understand this thing. We have 2 type of Raynaud. So just I'm writing here what is this Raynaud phenomena. We have 2 types of Raynaud. We have primary Raynaud and we have secondary Raynaud. So primary Raynaud means when Raynaud itself is a disease. And secondary means when Raynaud is due to some disease. So secondary means it is associated with some other disease. So primary Raynaud, understand, it is something, there is no disease here, it is due to certain triggers. Now what are these triggers? Now more the trigger, more will be the chance of Raynaud. So what are these triggers? So first trigger is cold climate, or I can say cold water. Then I can say second trigger will be excess emotional breakdown, emotions. Third will be any vibratory tools. So in primary, you will see any of these triggers. So more the trigger, more will be chance of Raynaud. So this Raynaud is something which most of you have observed in winter season. All of a sudden your nose become red, your earlobe become red, right? So this is what we call this Raynaud. So how we can protect from this? We can protect by using gloves and by using cap. But nose is something which we cannot protect. So most common site of Raynaud will be nose. So see, more the trigger, more will be chance. Suppose I can say a young girl living in Russia, that is cold climate, washing utensils with cold water. That means it is cold water is again a trigger. Then you can notice like a recent breakup, that means emotional failure. And now I can say she is frequently checking phone is having vibration. So more the trigger. So this is very commonly seen in beauticians. Like in my clinic, most patients with Raynaud, they come to, these are the girls, those who are working in some beauty parlor or salon. Because it is very common, because beauty parlor, salon, what they are using, hair massager, dryer, what this will have vibration, right? Now coming to, we have discussed primary, secondary. They ask you a question like, in Raynaud phenomena, you will see vasoconstriction in response to cold, stress, vibrations, and one more thing, emotions. Because you might have noticed some girls when they are crying, those who are very fair in color, when they cry, their nose will become red. So these are actually the findings that we see. Now they ask you what are the phases or color change sequence. So color change sequence you can remember by a mnemonic PCR. Now what is PCR? Understand this thing. PCR means initially it will be pale. Or pallor. See, for cyanosis, then ultimately it will become red. So PCR is pallor, cyanosis, red. So how we write this? How they ask you question? White, blue, red. So color change sequence will be white, blue, and red. This is color change sequence. Now understand this thing. If you ask me like what about a secondary Raynaud phenomena? So in secondary Raynaud phenomena, you will see in nine-fold capilloscopy, you will find dilatation and dropout. You will find dilatation and dropout of capillaries. And what are the complications that we see with secondary Raynaud? So in secondary Raynaud, you can see patient can develop sometime like gangrene, and sometimes there is ischemia in the legs. We call this critical limb ischemia. Critical limb ischemia. And one more thing patient can develop is gangrene. Okay, now coming to limited form. So limited form we call this Crest syndrome. So this Crest stand for Crest. C is calcinosis. Calcinosis cutis means calcium will precipitate somewhere in the skin. R is Raynaud. E is esophageal dysmotility. So patient will have esophageal dysmotility. Because of this reason, understand this thing. Some people, what they complain, they will complain of GERD or dysphagia. Then this S stand for sclerodactyly. Now look at my finger now. You can see in my finger there are 3-4 fold. Instead of this, if you get a flat finger, it is what we call absence of this fold. We call this sclerodactyly. It is called as sclerodactyly. Absence of folds on back of finger. T is telangiectasia. So this is what we call this Crest syndrome. Now what they ask you what are the antibodies? So the first antibody is anti-topoisomerase. So this anti-topoisomerase, we also call this anti-SCL70. It is something that we see in systemic form. So systemic sclerosis, we also call this diffuse form. It will have this antibody. Second antibody is anti-centromere. So anti-centromere is something which we see in a patient of Crest syndrome. Now understand this thing. Third antibody is what? Anti-RNA polymerase 3 antibody or RNAP3 antibody. So this antibody, understand this thing, this is something which you find in diffuse systemic sclerosis. This antibody is also seen in a patient like who is having scleroderma crisis, or we call this scleroderma renal crisis. So this is I can say one of the specific antibody. So you can see patient will have in rapid progressive skin region, you can find this. And this antibody you will find when the patient will have GAVE. GAVE is gastric antral vascular ectasia. We also call this watermelon stomach. You can also see like in malignancy and sometimes tendon friction rub. Anti-PMSCL antibody. This is PMS polymyositis, SCL70 is scleroderma, systemic sclerosis. What we call this overlap syndrome. So overlap syndrome means whenever patient will have polymyositis and scleroderma together. If any patient who is having overlap of these two things, then you will find which antibody? PMSCL. And they ask you like it will have nucleolar pattern on staining. So these are the antibodies which we see in a patient of scleroderma. Now, what they ask you sometime image-based question. So you can notice this is telangiectasia on the nail bed. This calcium will precipitate in the hand. We call this calcinosis cutis. Then you can see absence of folds in back of finger. There are no folds. We call it sclerodactyly. And sometimes like fingers become swollen because sausage finger. So sausage finger I told you where. Sausage fingers I told you many places where. Sausage finger you will see in psoriatic arthritis. Sausage digits you can see in scleroderma. Sausage digits you can see in a patient of reactive arthritis. Right. So these are, then you can see acro-osteolysis. If you see carefully that this part of bone is broken down. So what we call this acro-osteolysis. Acral part will have initially gangrene, then that will break down due to erosive arthritis. So these are the findings that we see in scleroderma. Now what they ask you what is scleroderma renal crisis. So understand, this is seen in what you think, superficial form or diffuse form. So of course it will be seen in diffuse form because diffuse form will have more visceral organ involvement. So it is seen there in a patient with diffuse systemic sclerosis. So it is seen there in a patient with diffuse systemic sclerosis. And they ask you which antibody. So we have anti-RNAP3 antibody. This is the expected question because it have not came till now, but it can be asked in future. So this anti-RNAP3, it is, I can say, most specific antibody where it is specific antibody whenever we have scleroderma crisis. Then we can find anti-topoisomerase. So now what they ask you when person will develop this crisis. So initially it will occur within, I can say, first 4 years or initial 4 year. Within first 4 years of disease onset. And what are the triggers? So triggers you can see like early steroid use in diffuse form. In diffuse form or diffuse scleroderma, it can precipitate crisis. In pathology, what you will find patient can develop thrombotic microangiopathy. We call this TMA, thrombotic microangiopathy. And patient can develop a very high BP. That what patient can develop secondary hypertension. So patient can land up in hypertensive emergency or urgency. So hypertensive urgency means BP is high but no organ damage. Hypertensive emergency means BP is high and some sign of organ damage. Now coming to patient can develop MAHA, there can be thrombocytopenia. Then what they ask you this question like what is drug of choice in scleroderma renal crisis. So remember, drug of choice in this condition will be ACE inhibitors. Why ACE inhibitors? Understand this thing because these are those drugs which can significantly reduce mortality. So these are those drugs which can reduce mortality. So these are most preferred drugs. Now they ask you overall scleroderma how we treat. So we can use methotrexate. We can use mycophenolate mofetil. And suppose if patient develop PAH means pulmonary artery hypertension. Whenever pulmonary artery pressure is more, in that case, what we can use endothelin receptor antagonist, or we call them endothelin inhibitors like bosentan, abrisentan,
And if it is not improved, then we can add like even 5 phosphodiesterase inhibitors like sildenafil, tadalafils. So just remember, they are also used to treat pulmonary artery hypertension. So this is about your scleroderma.
Okay guys, so next topic we'll discuss, that is called Sjogren syndrome. So Sjogren syndrome, basically we also call this dry syndrome. So you can see patient will have a lot of dryness in the body. There will be dry eyes, dry mouth, dry skin. If it's a female patient, so dry vagina. Now understand this thing. Dry eyes means, if you ask me what is most common cause of dry eyes, so just remember, for dry eyes, most common cause. Anyone? The most common cause of dry eyes, it will be your gadget abuse. Means, or I can say electronic abuse. Means you are using a lot of electronic gadget like mobile, laptop, TV. These are common causes. Now, patient can also have dry mouth, so there will be halitosis, bad smell from mouth. Then there can be dry skin. Because of dry skin, you can see itching, pruritus, and because of a dry vagina, this patient will have difficulty in sexual intercourse. So it is a multi-systemic autoimmune connective tissue disorder, means multiple organ systems are involved. So I can simply say this is second most common connective tissue disorder. So what is first most common? First will be rheumatoid arthritis. So understand this thing, it will affect middle-aged people, and generally females are more affected. And what will be the feature? You will notice like patient will have classical two findings. First is called dry eyes and dry mouth. So dry eyes, what we call this xerophthalmia, and dry mouth is called xerostomia. So 50% people, they have extra glandular manifestation. It can be serious. Like what are these extra glandular manifestations? So understand, they can develop vasculitis. They can develop renal tubular acidosis. There can be arthritis, patient can develop. Then some people, they can develop Raynaud phenomena. And lastly, I can say some of these people, they can also develop a lymphoma, that is called marginal zone lymphoma. So these are what? These are extra glandular manifestation. Okay, then they ask you what is a secondary Sjogren syndrome. So understand, secondary Sjogren syndrome is something, means Sjogren itself is a disease, we call this primary. Sjogren is due to some other disease, we call this secondary. So secondary Sjogren syndrome is something which is associated with other autoimmune diseases like RA and SLE. So it can be with all other diseases also. But remember, they ask you what is most common cause of secondary Sjogren syndrome. So answer is rheumatoid arthritis. So remember, Sjogren due to rheumatoid arthritis, SLE, scleroderma or any other disease, that is called secondary. Sjogren itself a disease, we call this primary. And most common cause of secondary Sjogren syndrome, it will be RA. Now what they ask you like what will be clinical manifestation. So there will be salivary gland swelling. Why this swelling will occur? So this swelling will occur because of bilateral, I can say parotid gland infiltrate. You can see bilateral parotid gland infiltration by lymphocytes. So lymphocytes will infiltrate into both the parotid gland, and that is why you will get the salivary gland swelling. Then why it occurs? So remember, it is an interleukin 18 mediated disease. It is due to interleukin 18 mediated disease. And most common gland involved will be parotid. So just now we have written parotid. It will be parotid gland. So Sicca syndrome is dry syndrome. And sometimes you will see like steroids are not that effective here. So when Sicca symptoms are prevalent, steroids are not effective. Then there will be asymmetric painful enlargement, and there is risk of lymphoma. I told you which lymphoma. There is increased risk of, remember, all the chronic inflammation will increase the risk of marginal zone lymphoma. And now tell me, this marginal zone lymphoma, it's a B cell or T cell? So remember, it is always a B cell lymphoma. It is always a B cell lymphoma. Okay, now coming to Raynaud phenomena. So you will see like patient can have a Raynaud phenomena. So sometime it may precede Sicca syndrome or Sicca symptom in some patients. Then we have glandular as well as extraglandular. So glandular means there is involvement of gland. So whenever you see involvement of a gland, then what you will notice? You will notice generally your lacrimal gland and salivary glands are affected. So patient will develop keratoconjunctivitis sicca. there will be keratoconjunctivitis sicca, right? And along with this, you will see when your parotid glands are involved, lymphocytes are accumulating there, the patient can develop xerostomia. So what is xerostomia? Xerostomia means patient will develop dry mouth. And in keratoconjunctivitis sicca, because of this, patient will develop dry eyes. So there will be dry eyes and dry mouth. So how we will approach the patient? So for dry eyes, in ophthalmology we do a test called shimmer test. So understand this thing, in a shimmer test we will assess the tear production in your gland. So you will find here a defective tear production. So there is a defective tear production. You will see less tear production. Now understand this thing. Then you will notice, like for this we use the strip. The strip is called rose Bengal strip. Rose Bengal strip. So what else we can do? We can also do a test. This test is like we can stimulate your parotid gland, and we can see even after stimulation saliva production will be lesser. It is called as iontophoresis. So iontophoresis means when you stimulate salivary gland, even after stimulation, remember, production of saliva will be less. Now coming to antibody. So antibody, what we find? We find anti-Rho antibody. So anti-Rho antibody, what we call? We call this anti-Rho or SSA. SSA means Sjogren syndrome A. So this antibody is something which is associated with early onset disease. Now they ask you, like, this antibody indicate long duration disease. So whenever, remember, any patient who is having this antibody titers in a higher range, this will increase the risk of extraglandular manifestation. It will increase the risk of extraglandular manifestation. Means higher the titer of this antibody, you will find more extraglandular manifestation. And this will also increase the risk of lymphoma. And just remember, higher titer is indicative of poor prognosis. Second antibody which we see is called anti-La. Anti-La is also called as SSB, means Sjogren syndrome B. So this antibody, understand this thing, this is also seen in Sjogren syndrome, right? And generally it is seen along with anti-Rho. Okay, this reminds me one more question, like this anti-Rho antibody, understand, this anti-Rho or SSA antibody, it is also seen in one more condition. Can you tell me which? This question came in one of the exams. So this anti-Rho antibody, just remember, it is also present where? In neonatal SLE. It is present in neonatal SLE. And how neonatal SLE will present you? So it will not present you like with, I can say, malar rash or butterfly rash. The neonatal SLE, just remember, it will present you with complete head block. So patient will have third degree AV block or complete head block. Now coming to how we make a diagnosis. So understand this thing, definitive test will be biopsy. So biopsy is the gold standard test. So this is the gold standard test to make a diagnosis. The gold standard will be biopsy. Okay, now understand this thing. So suppose we are having a patient of primary Sjogren syndrome. So what we see these findings like dry eyes. So whenever any person is having a dry eyes, what will be advised to these patients? So understand this thing. So we will advise the patient, first, keep your phone away when you are having Sjogren syndrome. Your phone watch time should be less than 3 hours in a day. Very, very important. Suppose when you are having iPhone, you can see your screen time. That screen time should be less. Second is, we will advise the patient like not to go in any humid area, or I can say not to go into smoking lounge where many people are smoking, or avoid prolonged standing in front of petrol pump, because you will see many automobile fumes. So we should advise the patient to avoid harmful environment like smoking lounge, petrol pump, or a factory smoke. Avoid excess, I can say, gadget use. So that is something we advise. Suppose if there is no improvement coming, then what we can give? We can give artificial tear. Artificial tears, these are made up of carboxymethylcellulose. If a person is having dry mouth, so for dry mouth, what you will do? For dry mouth, what you will do? You will tell the patient to drink water. Now suppose patient is telling you, doctor, I am drinking like almost 5 to 6 liter water and still having dry mouth, then what you will do? So see, dry mouth is common in those people who speak a lot, like people like speakers, teachers, singers, girls. So that is something which is causing dry mouth. So what we do, we advise the patient to drink a lot of water. Then what else we can advise? We can give some sugar-free lozenges, chewing gums, because they will increase your mouth secretion. Nothing is working, then we give a drug. That drug is called Synovitis. If suppose there is vaginal dryness, in that case, what we can give, we can use lubricant. We can use lubricants, right? This can be like estrogen lubricant or sometimes even non-estrogen lubricant. If it is dry skin, in that dry skin, what we give Garnier, Vaseline, moisturizers or coconut oil, simple moisturizers. So the treatment is symptomatic. If everything fails, you tried everything, nothing is working, the last option we have a drug that will increase all the secretion, and that drug is pilocarpine. Simple. Now coming to extraglandular. So the extraglandular, understand, we need to find the cause, means we need to treat the patient based on their cause. So just I am writing here what I told you in extraglandular. I told you patient can develop arthritis, patient can develop arthritis, patient can develop Raynaud, patient can develop vasculitis. Then understand this thing, patient can develop RTA. RTA means renal tubular acidosis, and a patient can develop marginal zone lymphoma. Marginal zone lymphoma. Now just understand this thing. So I told you symptomatic treatment for dry skin, for dry eyes, for dry mouth. Steroids are usually not having that promising response. Now coming to arthritis. For arthritis, what we should use? We can use NSAID, but again, it is rheumatological conditions, so better thing, the response usually comes with HCQS, hydroxychloroquine. In Rheumatoid, we will give patient some gloves. Tell the patient to use gloves and the cap, means cold protection, simple, cold protection. For vasculitis, we have one option, that is steroids, we will give steroid. For renal tubular acidosis, what we give? We give soda bicarb. And this marginal zone lymphoma, understand, it's a type of, I can say, non-Hodgkin lymphoma, B cell type. It is a B cell type NHL. So B cell type NHL, what is the treatment? We give R-CHOP therapy. So this thing we have covered in hematology part. We give R-CHOP therapy. So this is the management of extraglandular symptoms. So let's see now what it is written. So you can see NSAID, hydroxychloroquine. Why we give? We give this for arthritis. Then we can use steroid. Why steroid? For vasculitis. What else? You can see methotrexate, azathioprine, like mycophenolate, profiterol, cyclophosphamide. These are given for vasculitis and arthritis both, right? Then depending on the type of thing, if it is RTA, we have to give soda bicarb. Okay, let's see now what they're asking. They're asking you, like you can see extraglandular manifestation. What they ask you? Arthralgia arthritis. So it is non-erosive, but sometimes it can lead to Jacquard arthropathy. But just remember, in Jacquard arthropathy, the most common reason being complication of SLE, right? Then there can be fatigue arthritis purpura. This fatigue arthritis purpura, how you will manage this? Understand this thing. This is managed by, I told you, NSAIDs, and alternative will be HCQS. Raynaud phenomena. So how you will manage? Cold protection. So we can give cold protection gloves. Suppose if any patient is coming to with lymphadenopathy, we should always rule out lymphoma. And suppose if you are ruling in lymphoma, then we should start R-CHOP therapy. Then what they ask you, suppose if a patient is having vasculitis. So in vasculitis, what you will notice, if it is vasculitis, understand, you will notice that patient will have cutaneous involvement. So most common finding you will see is cutaneous palpable purpura. You can notice there is cutaneous palpable purpura. So standard treatment means what we give in vasculitis, we give steroids. Now coming to kidney involvement. So when patients have kidney involvement, you can see there is interstitial kidney disease. Then you can notice glomerulonephritis. This glomerulonephritis, understand, this is generally which is associated with cryoglobulinemia. Cryoglobulinemia. And this can involve the tubulointerstitium, and patient can develop a distal type of RTA. We call this type 1 or distal RTA. So how we manage RTA? We give soda bicarb. In RTA, what we give? We give soda bicarb. Now coming to lymphoma. So again, you can see patient can develop gastric maltoma. There can be gastric maltoma. Then along with this, remember, patient can develop marginal zone lymphoma. There can be marginal zone lymphoma. So what we give? We give R-CHOP regime. R-CHOP, just remember this R stands for rituximab. So we give chemotherapy based on rituximab. So this is how we manage all the extraglandular manifestation. Now they ask you what is most common. Most common extraglandular manifestation will be fatigue. Then arthralgia, arthritis, vasculitis. So most common will be fatigue. Okay, they ask you what is the differential diagnosis of bilateral parotid enlargement. So you can see bilateral parotid enlargement you can see in Sjogren's syndrome and as well as in sarcoidosis. So how we differentiate, understand this thing. If you see in Sjogren's syndrome, antibodies are present. So just remember here antibodies are present. And which antibody? Anti-Rho, anti-La. In sarcoidosis, you will see antibodies are absent. So sarcoidosis is considered diagnosis of exclusion, no antibodies. Now coming to lymphoid infiltrate. So you can see in Sjogren's syndrome, you will see there will be lymphocyte infiltrate by CD4 T cells. So you can see lymphocyte infiltrate. And this infiltrate will be by CD4 T cells. But here in sarcoidosis, what you will see, you will notice patient will have granuloma. Here patient will develop granuloma. Now when we talk about association with HLA, so understand this thing, Sjogren's syndrome is something which is having HLA-DR3. HLA-DR3. You can see like patient can have HLA, I can say DQ2, and there is an HLA called DRW52. In sarcoidosis, you will see there is no such HLA association. Now coming to, I can say serological testing for HIV. So remember, in this you will see negative. In sarcoidosis also you will see negative. In fact, I can say sarcoidosis will provide protection from HIV because understand this thing. In HIV, what happened? In HIV, symptom will develop when CD4 count will reduce, and in sarcoidosis, symptom will develop when CD4 count is more. In sarcoidosis, symptom will develop when CD4 count is more. So this is why I can say they both are protective towards each other. Clear? So this is about your, I can say, difference between Sjogren's syndrome and sarcoidosis. Now let's talk about IgG4 related disease. So these are diseases which are seen in old people and mainly they affect males, and presentation of disease will be subacute. Now they ask you like what is a trigger. So trigger will be a chronic antigen stimulation, and this chronic antigen stimulation, it is mediated by a molecule called galectin 3. It is mediated by galectin 3. So this is like a topic which they mostly ask on INICET, right? Not that important for NEET PG, but they ask you on INICET. Now coming to symptom patient can develop, there will be constitutional symptoms. There is no as such fever or arthritis. Then what is the pathophysiology? Understand this thing. There is chronic antigen stimulation, and what I told you, this antigen stimulation, it is by which molecules? Galectin 3. So the result of this, you will see there is increase in level of IgG4. So that's why we call them IgG4 disease. This IgG4 levels are more. So what they will do? They will activate myofibroblast. They will activate myofibroblast. And what these myofibroblasts will be do? Understand this thing. What they will be doing? They will start producing collagen. So there is more collagen formation. There is more collagen formation. So ultimately you will see there is like fibrosis pathway. This fibrosis pathway is always driven by TGF beta. So whenever you see TGF beta driven fibrosis, and along with this you will see patient will have inflammation. So this is the pathophysiology that we need to understand for IgG for related disease. Now they ask you what are the manifestation. So suppose first organ that is affected will be pancreas. So in pancreas, what they can cause? They can cause a type 1 type of autoimmune pancreatitis. So most common finding will be type 1 autoimmune pancreatitis. So this is most common finding. So generally this is something which affect young people. Patient can develop obstructive jaundice. There will be feature of acute pancreatitis, means lipase amylase will be increased by more than 3-fold. Then you can see there will be exocrine as well as endocrine insufficiency. So this is what we call this like now see, when patient will have like damage in the beta cells, it will not allow insulin to release. So we call this type 3C diabetes mellitus. We call this type 3C diabetes mellitus. And what they ask you like how you will see the pancreas. So pancreas will look a little bit bulkier like a sausage. We see sausage shape large pancreas. Sausage shape large pancreas. And this pancreas will be having irregular borders. Coming to next, salivary gland. So understand this thing. In salivary gland, you will notice there will be swelling of submandibular gland. So you can notice patient will develop submandibular gland swelling. Submandibular gland swelling. This swelling is painless, bilateral and symmetrical. And understand this thing, this swelling, understand this, whenever you see parotid or submandibular lacrimal gland swelling, previously it was called Mikulicz syndrome. We call this Mikulicz syndrome. So previously it was called Mikulicz syndrome. Understand this thing, sometimes you will notice like patient will have like lacrimal gland swelling. When you see lacrimal gland swelling, so patient can develop like a minor version of SETIYA syndrome. Is you can see, I can see some sort of dryness. So you can see minor version of SETIYA symptom will present. So minor SETIYA symptom you will see. Then you can notice sometimes there will be retroperitoneal fibrosis, and this is something which can cause a bilateral obstructive nephropathy. It can cause a bilateral obstructive nephropathy. Now, what are some minor manifestation? So understand, minor you can notice like patient can have like postpartum headache, that is due to lymphocytic hypophysitis, that is inflammation of pituitary. Then there can be pachymeningitis, means brain parenchyma is not involved. So it means patient will have symptoms of meningitis. Then in eyes you can see sometime there is like increase in intracranial pressure, so patient will have a pseudo tumor like appearance. We call this orbital pseudo tumor. So there is orbital pseudo tumor. So it's not a tumor. There is a painful inflammatory mass. It's not a malignant tumor. It is not a benign tumor. It's like a growth, just a growth. You just remember pseudotumor also you can see whenever we consume a lot of OCPs and vitamin A. So vitamin A toxicity and OCP can also cause pseudotumor cerebri. Then in lungs, what you can notice there will be bronchovascular bundle thickening. There will be a non-specific, I can say interstitial pneumonia. There is, understand this thing, because of this there is NSIP, means non-specific interstitial pneumonitis. This will increase risk of ILD. It can increase the risk of interstitial lung disease. Then sometimes you can notice there will be a paravertebral mass, or I can say a paravertebral tenderness is seen. Then remember they ask you in the vessels. In the vessel you will notice like there will be vasculitis. Generally it will involve aorta. So what we call this proximal aortitis. Proximal aortitis. This is like a vasculitis that affect the aorta. So it is actually affecting the only vasculitis which affect proximal part of aorta. Other vasculitis like Takayasu can also affect, but they mostly affect the other part. Now coming to, there will be some changes in the biliary tract. There will be some changes where in the thyroid, kidney. So what are the changes in the biliary tract? They ask you like there will be IgG4. We call this IgG4 sclerosing cholangitis. IgG4 sclerosing cholangitis. Right. So previously we were calling this primary sclerosing cholangitis, but now remember, primary sclerosing cholangitis is something that is associated with ulcerative colitis. Now coming to thyroid, so in thyroid involvement, you will notice like patient will have non-specific involvement of thyroid. You can notice like some people can have symptom of hypothyroid, some can have symptom of hyperthyroid. So there is no specific inflammation of thyroid. Then you can notice there will be like tubulointerstitial nephritis, there will be membranous nephropathy, and generally here you will see low complement level. And lastly, what I can say, like patient will develop lymphadenopathy. So these are the findings what we see in a patient of IgG4 related disease. Now coming to histological finding, you will find the pattern. This pattern is what we call this storiform fibrosis. So there is storiform fibrosis. There is storiform fibrosis. It is like a swirling or cartwheel type pattern. Then you can notice like sometimes there will be like lesions which we call tumefactive lesion. There will be tumefactive lesions, or these are basically the lesions that we see in lymphadenopathy. This can lead to sometimes mild eosinophilia. There is no fibroid necrosis or no granulomas here. You will not find this thing. Now understand this thing. What else they ask you? They ask you like, suppose if a patient who is having salivary gland involvement like dacroadenitis, plus you can note it parotid and submandibular gland swelling. So what we call this? So what we call this previously, what I told you, it was previously called Mikulicz syndrome. Mikulicz syndrome. There can be like fibrosis in the thyroid gland, so there will be radial thyroiditis. There can be retroperitoneal fibrosis, there can be orbital pseudotumor, and sometimes there can be biliary strictures. So how we make a diagnosis? So understand this thing, IgG4 related disease. So you can see more depository findings. So in serum it may be increased, in serum it may be elevated, or in sometime you will notice it can also be normal. So how we make a diagnosis? To make a diagnosis, because IgG4 is depositing, so for this we need to do biopsy. So in biopsy, what you will notice increase in the level of IgG4, right? Or I can say this IgG4 is to IgG ratio will be increased. So you can say IgG4 value will be increased, or I will say there is IgG4 is to IgG ratio will increase. This ratio will increase in sample. Now coming to treatment, so first line treatment will be steroid. So we will give steroid, and when we give steroid, remember there is an excellent response you will see in initial 2 weeks. But suppose if it is like a relapse, in this case relapse case, what we need to give, we need some steroid sparing agent. So the drug that we use is rituximab. So this is about your IgG4 related disease in detail.
Okay guys, next topic we'll discuss, that is myopathies. So here we have two conditions, dermatomyositis and polymyositis. So understand this thing, derma means skin, myo means muscle, itis means inflammation. So this is a patient who will come to you with skin and muscle involvement. So possibility is this person can go to a dermatologist. Then if you see a polymyositis means it will involve many muscles. So this is a patient who is coming into rheumatology clinic, or I can say general medicine, or to general physician. So when they ask you like both are involving muscle, so you can see muscle is common thing. So what are the similarities we see? So first let me just talk about similarities. So you see dermatomyositis and polymyositis, these are the condition which will affect females more often. So first similarity, they will affect females. Then I can say second similarity you will see in both are autoimmunes. In so both are autoimmunes, you will find antibody called anti-Jo1. Then I can say both diseases are involving muscles. So patient will have myalgia. There will be myalgia means muscle pain. There will be fatigue. Then both are involving muscles. So understand this thing, when you do electromyography in both the case, that will becoming abnormal. So electromyography in both the case will come abnormal. Now let's say suppose when you do muscle biopsy, you can find a perifascicular atrophy.
So there is perivascular atrophy in both. Perivascular atrophy you will see in both. Then since both are autoimmune, so we have one option in treatment of both. What we give steroid. So these are what? These are similarities that we see in both the condition. Okay, one more thing I can say, when muscles are breaking down, you can see then CPK MM, the fragment which is present in your muscle, that will come out. So CPK MM will increase in both. CPK MM will increase in both. CPK MM is for muscle, CPK MB is for heart, CPK BB is for brain. Let's understand now. So if you see both are affecting 40-60 years female. So generally female is to male ratio is 2:1. Then you can see like in polymyositis you will see it will affect only adults. But in case of dermatomyositis you can notice like sometime a juvenile group is also seen. So when you see like about a polymyositis you can notice like this is generally it can occur alone or in a part of overlap syndrome. So generally you will see patient will have overlap syndrome. What is overlap syndrome means? Patient will also have some other autoimmune condition like polymyositis plus scleroderma. Then if you talk about dermatomyositis, this can occur independently, or it can occur as a part of overlap syndrome. So again, understand this thing. Polymyositis is mostly seen with other condition. Dermatomyositis can be seen alone. Now understand this thing. Here skin features are not seen. Here you will find some skin features. Now coming to presentation. So you can see there will be bilateral symmetrical muscle weakness. So it will involve bilateral muscles, and this will start over a span of 3 to 6 months. And generally what I can say, you can notice like lower limbs are more affected compared to upper limb. Then very important, like these both disease will involve proximal muscles. So again, this is something which you need to understand. One more similarity I'll write here. Both will involve proximal group of muscles. There's a type of myopathy we call this inclusion body myositis. That is something which can involve distal muscles. So this will involve proximal muscle. Proximal muscle means, what I mean to say is this muscles or thigh muscles. It will not affect these distal muscles. There is no sensory findings. Reflex are present. Bowel and bladder movement will be normal. So these are all the findings which we can see here as well. Same. So these are the similarities which we can see in dermatomyositis and polymyositis. Now coming to a biopsy finding, you can see there is no necrosis in both. And when you do biopsy, in biopsy what you will find? So in biopsy what you will find here, there is proliferation of CD8 T cells. So CD8 T cells. In dermatomyositis you will find both T cells as well as B cells. So you will find CD4 T cells, and you will find some B cells as well. Now they ask you what is the gold standard test. It is muscle biopsy. And in biopsy what you will find, this is an MCQ which they ask, endomysial perimysial inflammation. And you will notice here you will notice like there is perivascular inflammation. And this term which is usually given in MCQs, that is perivascular atrophy. So in biopsy you will find in both the case you can see endomysial perimysial inflammation and perivascular atrophy. So this perivascular atrophy even you will find here also. Okay, now look at this. CPKMB is positive. Positive means it is elevated. Again, it is elevated in both. Now try to understand. They ask you what are the skin changes. So let us see some skin changes. So skin changes, these will be features of dermatomyositis. So starting with the first, you can see there is a rash, a peri or vital rash. This violaceous erythematous rash surrounding the orbit is what we call this heliotropic rash. So this is an MCQ which they ask in exam. Now in the knuckles, again, so in the knuckles you will find again a papular rash. These papules are called Goutron papules. These are called Goutron papules. So this question also they have asked in exam. Then you can notice like some of these patients they can develop telangiectasia. Then there will be a rash in the back where people are wearing shawl. So we call this shawl sign. Similarly, sometimes you can see a rash in the V area, means like we wear V neck t-shirt. In that area, you can see a rash. We call it V sign. V sign. Sometimes you can see a rash in the sleeves area where we people are wearing sleeves. We call it sleeve sign. And you can also see rash in anterolateral aspect of thigh. We call this holster sign. Holster sign. So just I am highlighting this once again. Look at the screen. Heliotropic rash, Goutron papules, telangiectasia, shawl sign, V sign, sleeve sign, holster sign. These are all the cutaneous sign. So these are all the cutaneous signs, and remember these are the skin signs. So where we see them, these are seen only in a patient of dermatomyositis. Okay. Okay, they ask you what are these Goutron papules. So these are basically hallmarks of juvenile dermatomyositis. These are scaly, flat-topped pruritic papule which we see in the knuckles. So this is about your dermatomyositis. Now what they ask you suppose you are having a patient. What are other types of and just let me say, complete this. What we can say in treatment for both, what we give steroid. So steroid will be given in both. Just one difference I will say, there is an antibody called anti-MI2. It is seen only in dermatomyositis. Right. So diagnosis, for confirming diagnosis, we'll find antibody. To confirm diagnosis, we find antibody. So antibody like anti-Jo1, and to confirm, to make it 100% sure, what we have to do biopsy. And biopsy will find you will find perifascicular atrophy, you will find infiltrate. So these are the findings which we see in biopsy. Now coming to other types of I can say myopathies which we see. So first is immune mediated. Immune mediated, understand this thing. In this immune mediated, you will see necrotic muscle fiber. And next important one, this sometimes they ask in exam. We call this inclusion body myositis. This is something which is important. It is a type of myopathy which we see in old people, elderly male. Sometimes also you can see in elderly female. And generally these elderly people, they are having some association with cancer. So for example, suppose a 70-year-old patient with colon cancer or prostate cancer, they will give you some hint of cancer and old, very old. And this is involving proximal and distal. And in fact, I will say it will mainly involve distal. So distal is more involved than proximal. So it will mainly involve distal, like it will involve forearm muscles, leg muscles. Okay? Here also you will find endomysial and perivascular inflammation, but you will find same CD8. And the classical feature, you will find a vacuolar structure. These vacuoles are seen. These vacuoles are called rimmed vacuoles. Rimmed vacuoles. Next differential diagnosis will be polymyalgia rheumatica. So polymyalgia rheumatica, understand this thing. This I think we have discussed somewhere. So it is something which is seen in a patient of giant cell arthritis. So giant cell arthritis, also called as temporal arthritis. So you can see this in a patient of temporal arthritis. So temporal arthritis patient, generally they will have involvement of temporal artery. They can complain of headache, but sometimes these patients, remember, they will have a diffuse muscle pain in the back, in the shoulder, in the lower calf area, anywhere. So patient is generally above 50. So patient will complain of like pain and stiffness of hip, shoulder, pelvic girdle. So there will be pain and stiffness of hip, pelvic, and I can say shoulder. So pelvic girdle and shoulder. Then you will notice like generally I told you there's a rule of 60 in giant cell arthritis. Like it is seen in female above 60, ESR is more than 60, and treatment will be 60 milligram prednisolone daily. So you will notice like ESR is generally more than 50, or I can say more than 60. So ESR is very high. Then remember, like patient will also complain. It's a rheumatica, means rheumatological picture. So rheumatological picture means what you will notice, patient will have morning stiffness like rheumatoid arthritis. So there will be morning stiffness like rheumatoid arthritis. Now they ask you like, what about CK? So it is not purely a muscle disease. So creatine kinase will be normal. Creatine kinase will be normal, and they ask you like how you will manage this. So when you treat this, there is, remember, always a good response to steroid. So it will show an excellent response to steroid. So what this is one question they have asked. Polymyalgia rheumatica, it is classically associated with which vasculitis? Answer is giant cell arthritis. Now understand this thing. They ask you what are other types of myopathy. So we have inflammatory myopathies. In this you will notice ESR is raised, CK is raised, and proximal. So inflammatory myopathy means same like what we are discussing, dermatomyositis and polymyositis. Then we have steroid induced. So steroid induced, understand this thing. Now when we give steroid induced or we give steroid to a patient, so steroid they will mask the inflammation. So what you will notice like ESR of the patient will now come normal, right? And even CK will come normal. So steroid can cause myopathy, but they will mask the inflammation, they will suppress the inflammation. So these acute phase reactant of inflammation, they will not come elevated. So ESR, CK will be normal. Then remember the steroid induced, it is also involving proximal muscle. So till now, I have told you just one condition which was involved with distal muscle, that was inclusion body myositis. Then remember in steroid induced, steroids are also having anti-inflammatory action. They are strongest, I can say, anti-inflammatory drugs. So there is no pain in this. So muscle will become loose, but there is no pain in steroid induced myopathy. Okay, next is statin induced. Now understand. Statins are like HMG coenzyme reductase inhibitor drugs. So basically these are the drugs which we use to treat dyslipidemia. So they act on HMG coenzyme reductase. So when you give statin to patient, they ask you here again ESR will come normal because there is no as such inflammation. Then you see but statin will cause rhabdomyolysis, so muscle will release creatine kinase. So creatine kinase will be increased and patient will come to you with pain. So there will be pain. But there is no as such weakness. Then they ask you hypothyroidism induced myopathy. So hypothyroidism, understand this thing. Here you will see ESR is normal. Creatine kinase can be raised. It's also involving proximal muscles, and sometimes you will see delayed reflux. This delayed, actually it is delayed relaxation of ankle jerk, and this delayed relaxation means once you see, you will trigger the reflex. There is a contraction, but relaxation is delayed. This delayed relaxation is called as hung up ankle jerk. Hung up ankle jerk. We call this hung up ankle jerk. Okay. Now we have anti-synthetase syndrome. So anti-synthesis syndrome is something which we see in patient of both polymyositis and dermatomyositis. And they ask you what is the name of antibody. So here what we see anti-Jo1. We will see anti-Jo1. It is anti-amino acid tRNA synthetase. So patient, again, here you will see proximal or distal. So you will see proximal muscle weakness. So just remember when a question is coming to you with distal muscle, think of inclusion body myositis. Features, you will see patient will have fever. Then you can see SLE like arthritis. There will be interstitial lung disease. Then sometimes you can see like a patient will have a lot of a tight or thickening in the hands. Suppose if I ask you a doctor or I can say a mechanic or a laborer who is having a tighter palm, so that means a laborer or mechanic. So these type of hands are called mechanic's hand. We call them mechanic's hand. So mechanic's hand, understand this thing, what it is. Mechanic hand is nothing, you will see crusting. You can say this. What is mechanic hand? It is crusting and erosion. So patient will develop crusting and erosion, right, on radial aspect of finger, on radial aspect of generally index and middle finger, radial aspect of index and middle finger. So what we call this? We call this mechanic hand. Then a patient in this condition, this thing, they can also develop Raynaud. So there is chance they can develop Raynaud. So they can develop Raynaud's phenomena. In biopsy, you will find same perimycial or perivascular inflammation with CD4 and necrosis. So this is about your anti-synthetase syndrome. Now I can say fibromyalgia. So this fibromyalgia, understand this thing, it is something like which we diagnose very late. So it is again more common in female, generally 20 to 50-year-old. So what we see here, you can see a chronic widespread musculoskeletal pain.
And this musculoskeletal pain is something which is associated with some certain tender points. Means patient will complain he is having pain on certain areas. So you can notice there will be certain tender points. Certain tender points. So this is like something where patient can have poor sleep. There will be fatigue. You can notice like inflammatory markers like ESR, CRP, they will be normal, and patient will have some somatic symptom, or they can also develop tension headache. So the classical differential diagnosis which we see, it is the differential diagnosis is chronic fatigue syndrome, CFS. So chronic fatigue syndrome will mimic fibromyalgia. And if you see like these are certain things you can notice, like there will be pain in the knee, gluteal muscles, ribs, cervical vertebra, lateral epicondyle. These are certain tender points, and here only patient will complain of pain in a patient of fibromyalgia. So this is about your fibromyalgia. Okay guys, now let's talk about rheumatology. So it is again a very simple and sweet topic. So first thing that we'll discuss will be vasculitis. So what is vasculitis? Understand this thing. Vasculitis means simply inflammation of vessel. So based on size of vessel, we can classify vasculitis into three categories, like large vessel, small vessel, medium vessel. So understand this thing. In a large cell vasculitis, what we have, large vessel vasculitis, we have giant cell arthritis. Giant cell arthritis is also called as temporal arthritis. Temporal arthritis. And second is called Takayasu's arthritis. So just remember 2T, temporal and Takayasu's. These two T's are example of large vessel. Takayasu arthritis, understand this thing. Here you will see involvement of aorta. So it will involve non-specific branch of aorta. So we also call this pulseless disease. So it is also called as pulseless disease. Now coming to medium vessel. So medium vessel vasculitis, understand this thing. They will involve vessels which are medium in compared to large vessel. So here I will give a mnemonic like Pandit's Kawasaki bike. Pandit's Kawasaki bike. So first three alphabet of Pandit. Pandit means pan. It is your pan. Pan means polyarteritis nodosa. Kawasaki itself is a disease. So Kawasaki is Kawasaki disease. And bike, understand, bike stand for Berger's disease. But just pay attention, the spelling of Berger, it is B-U-E-R. Berger's disease. Berger disease is also called as tau. Thromboangiitis obliterans. So this is one classification. Okay, just don't confuse this Berger with B-E-R-G-E-R, Berger. So this Berger which I am writing in front of you, this Berger is another name of IgA nephropathy. So basically this is something, a type of glomerulonephritis. So it is a type of nephritic type of glomerulonephritis. So this we'll discuss in detail in kidney section. Then coming to small vessel. So when they talk about small vessel, so understand this thing. In small vessel you will see action of certain antibodies. So here we have diseases like granulomatous with polyangiitis. This was previously also called as Wegener's granulomatosis. Wegener's granulomatosis. Then sometime you will see a condition where granulomas are absent. So here you will see in the name is there granuloma. So here granulomas are present. Wegener's granulomatosis or granulomatous polyangiitis. Next condition where granulomas are absent, we call this MPA. MPA is microscopic polyangiitis. Microscopic polyangiitis. Third disease here will be Churg-Strauss syndrome. We call this Churg-Strauss syndrome. And fourth condition here, it is called HSP. HSP is Henoch-Schollen-Purpura. So now understand this thing. HSP, basically we can divide this like, we can devise a small vessel like, suppose if you have ANCA involvement. So ANCA involvement, how to see this? In ANCA involvement you will see in these three. Like Wegener's will have C ANCA, microscopic polyangiitis and Churg-Strauss will have P ANCA. Sometimes you will see immune complex. So immune complex you will see where? You will see this in Henoch-Schönlein purpura. This is nowadays they are asking you question like it is also called as IgA vasculitis. IgA vasculitis. Then we have a rare type called cryoglobulinic vasculitis. So this is something which is associated with hepatitis C. We also call this essential mixed cryoglobulinemia. Then we have good pasture syndrome, and sometimes you will see like hypocomplementemic urticariac vasculitis. It's very, very rare. So here you will find an antibody called anti-C1q antibodies. Anti-C1q antibody. So this is something that you should know about vasculitis. So in a nutshell, what I can say, we can divide vasculitis into large vessel, medium vessel, small vessel. So large vessel, remember 2T. Large vessel 2T. 2T means temporal Takayasu. Medium vessel Pandit Kawasaki bike. Small vessel, just remember Wegener's gallomatosis, microscopic polyangiitis, Churg-Strauss syndrome, and Henoch-Schönlein purpura. These are important things which they ask in exam. They ask you question all except fashion. Now understand this thing. Sometimes you will see some variable vessel involvement. So we don't know, like sometimes it involve large, even like there is a condition called Cogan syndrome. So Cogan syndrome, understand, it mainly involve large, but it can also involve medium to small vessel. Then there is one more condition called Behcet syndrome. Behcet syndrome we also call the Silk Road disease. So Cogan syndrome and Behcet syndrome, these are something which involve variable vessel. Even like just remember, Cogan predominantly involve large vessel. Okay, now let's understand this thing. What is Cogan syndrome? So Cogan syndrome patient, Behcet will discuss in detail. So in Cogan syndrome you will see patient will have aortitis, interstitial keratitis, and vestibulitis. Means patient, because of vestibulitis he will develop SNHL. SNHL means sensory hearing loss. So this is something which we see in a patient of Cogan syndrome. They can ask you like, we have single organ vasculitis, means only one particular organ is involved. Then we can say secondary vasculitis. So they ask you what are secondary organs, or I can say diseases, what are other connective tissue problem which can cause vasculitis. So most common, understand this thing, out of this most common will be immune complex mediated. Most common is immune complex mediated vasculitis. And always remember, wherever you see immune complex, now tell me this is which type of hypersensitivity. See, type 1 is anaphylactic, type 2 is cytotoxic, type 3 is immune complex, type 4 is delayed. So type 3, type 1, type 2, type 3, type 4. So this is your type 3 hypersensitivity. So immune complex, it is seen where? In type 3 hypersensitivity. Done. Now coming to rheumatoid arthritis. So see, rheumatoid arthritis patient will develop a vasculitis. So this vasculitis can involve your I can say arteries of your lower limb especially, so they can later on complicate to form gangrene. So in rheumatoid arthritis, remember, it can complicate to form gangrene, and some people they have like involvement of GI vessels, so it can lead to GI vasculitis, gastrointestinal vasculitis. So although remember, GI vasculitis is commonly seen in PAN. PAN is polyarteritis nodosa. Then similarly in SLE, you can see GI vasculitis, same. So SLE can also involve GIT. But in SLE you can also see some small brain vessels will be involved. We call it CNS vasculitis. So in SLE you can see CNS vasculitis as well as GI vasculitis. Okay, so they ask you what is only connective tissue disorder causing aortitis. This will be IgG4 related disease. Then some lymphoproliferative malignancy can cause vasculitis. Some drugs can cause vasculitis by two ways. Either it produces some hypersensitivity or it can trigger the release of ANCA. So they ask you what are the common drugs which can cause vasculitis. What are common drugs you know? So first drug is hydralazine. Now you tell me where we use hydralazine. So hydralazine basically it is a vasodilator which is used to treat hypertensive urgency and emergency. Right? Even nowadays like hypertensive urgency, emergency, we give labetalol followed by nitroglycerin. But in some places still we use hydrolysine, nitroprusside. These are the drugs like we sometimes use to treat hypertensive urgency or emergency. Coming to next is PTU, propyl thiouracil. Where we use PTU? It is used in hyperthyroidism in pregnancy, right? And we also use to treat thyroid storm, right? PTU. So basically in non-pregnant hyperthyroidism, what we give carbimazole and methimazole. In pregnancy, we give PTU. Then remember, next drug is an antibiotic. This is called minocycline. Minocycline. Just remember minocycline. They ask you one more MCQ. It is like an antibiotic which now we don't use routinely. It's a drug which can also trigger. Just I am recalling an MCQ. It can also trigger a condition called autoimmune hepatitis. It can also trigger autoimmune hepatitis. And this question came in 2023 NEET PG. Then next drug, it is basically an anti-parasite drug. Basically, we use this to treat hookworm infection. That is levamisole. So these are 4 drugs which can cause vasculitis. Okay. Now understand, there are certain infection which can cause vasculitis. So they ask you which infection. So these both MCQ came in exam. And on multiple occasions they came. So which vasculitis? So just remember 30% of patient of PAN. 30% patient of PAN, they will have hepatitis B surface antigen positive. So they will have increased risk of hepatitis B. So hepatitis B virus, this is associated with PAN. PAN means it's a medium vessel vasculitis, polyarthritis nodosa. Then I can say hepatitis C infection. Hepatitis C infection, it will cause cryoglobulinic vasculitis. Also we call this essential mixed cryoglobulinemia. So it will cause cryoglobin, or I can say cryoglobulinemia or cryoglobulinemic vasculitis. So sometimes we call this essential mixed cryoglobulinemia. Then they ask you ANCA associated. For this, just I want to explain something. Just try to understand this thing. Suppose this is an antibody. So in antibody, you will see we have cells and their nucleus. Cells and their nucleus. So let's say here we have nucleus. Here we have nucleus. So surrounding the nucleus, what we find, surrounding the nucleus, we have an enzyme. And this enzyme is what we call, this enzyme is called MPO. MPO means myeloperoxidase. And somewhere in the cytoplasm, here we have receptors. This receptor is called as protease receptor 3, PR3. Clear? So surrounding the nucleus, we have MPO. If you develop antibodies, suppose if you develop antibodies against this enzyme, so this antibody is what we call, suppose if we have antibodies, so let me just draw certain antibodies. So if you have antibodies against this enzyme surrounding the nucleus, so this antibody is called as anti-MPO antibody, anti-myeloperoxidase, and this is surrounding the nucleus. So just remember, it is also called as PANCA. So what is PANCA? PANCA is nothing. It is another name of PANCA will be anti-MPO. And if you find antibody somewhere here, if you find antibody here means against this receptor, means somewhere in the cytoplasm. So we can call this anti-PR3, anti-protease receptor 3, or in the cytoplasm we call this C-ANCA. Clear? So we have 2 types of ANCA, P-ANCA and C-ANCA. So these are 2 types of ANCA. ANCA is anti-neutrophilic cytoplasmic antibody. So we can have P-ANCA, we can have C-ANCA. So they ask you where we see P-ANCA. So P-ANCA you will see in a patient with Churg-Strauss syndrome. You can see this in a patient with microscopic polyangiitis. How to remember this? Remember PCM. PCM means physics, chemistry, math, or you can say simple paracetamol. P, C and M. Done. And how to remember where we see C-ANCA? So C-ANCA you will see in a patient with Wegener's. I don't like this name, Wegener's. So let me just write Wegener's. C. Wegener's. So Wegener's means C for C-ANCA. Is it clear? So they ask you P-ANCA is seen in all Excel. So P-ANCA you will see where in Churg-Strauss microscopic polyangiitis. So now try to understand.
It is anti-neutrophilic cytoplasmic antibody, and what we call this? We call this ANCA. So if you find antibodies, understand this thing, if you find antibodies against like PR3, or we call this proteinase receptor 3, what we call this? Or we can have antibodies against MPO. MPO means myeloperoxidase. Myeloperoxidase. So understand this thing. Anti-PR3 means, anti-PR3 is your CANCA, and anti-MPO it is your PANCA. So this antibody, understand this thing. This ANCA study, how we screen. So for screening, how we can test ANCA? So ANCA screening, understand, we can do like indirect immunofluorescence. And to confirm this, understand this thing, what we can do? We can do ELISA. Just remember, for confirmation also we can use immunofluorescence. Is it clear? So understand this thing, ELISA will just tell you the test is positive or negative. So sometimes it can be false positive, it can be false negative. And in immunofluorescence, so just I'm writing here, ELISA will tell you just test is positive or negative. But in immunofluorescence, you will get the value of titer. You will get the value of titer. And this titer value, understand, when they are more than 1:160, then it is considered positive. Right? Basically, these are the titer of different antibody will have different titer. So just remember, in immunofluorescence you can get a value of titer. Okay, so understand this thing, the titer which I was telling about 1:160, that is actually the titer of ANA, anti-nuclear antibody, right? Okay, now coming to PANCA, CANCA, you can see perinuclear or PANCA, what we call this? We call this anti-MPO, and CANCA, anti-PR3. So what they ask you, PANCA, where we see? PANCA is positive where? Yes, PCM means Churg-Strauss syndrome and microscopic polyangiitis. And CANCA, where we see? In Wagner's, or you can say Wagner's granulomatosis. Am I clear? Then what they ask you what are the difference between different types of vasculitis. So in immune mediated we have two things, IgA vasculitis also called as HSP, Hannock-Schollen purpura, and we have cryoglobulinic vasculitis, we also call this essential mixed cryoglobulinemia. Essential mixed cryoglobulinemia. Now understand, in IgA vasculitis you will see immune complex, here also you will see immune complex, so both are immune complex mediated and both are generally involving small vessels. But just remember, IgA vasculitis is something which is commonly affecting children and they affect generally males. So I can say it is most common, actually it is most common vasculitis of children. So in children it will cause a mild disease. So usually it is not affecting adult, but when it's affecting adult it will cause more severe. It will have more severe involvement. And cryoglobulinic, it will affect your middle-aged female. Now what they ask you, like what are the manifestations? So you will see patient will have one finding you will see in almost all patients, that is there will be 100% people will have, it is a non-thrombocytopenic purpura. It is non-thrombocytopenic palpable purpura. So understand this thing, patient, this baby will come to with a palpable purpuric rash. Then sometime you will notice like generally this rash is seen in lower limbs, in the hips, in the buttocks area. Then sometimes you can see it can cause ulcers, it can cause gangrene. In case of I can say essential mixed cryoglobulinemia, you will see patient will have purpura. There will be involvement of medium vessels. Then understand this thing, in IgA vasculitis, what else you will notice? You will notice a patient will have involvement of GIT. So most patients, they will come to you with rash and severe abdominal pain. So that is called abdominal angina. Abdominal angina means patient will complain of severe abdominal pain. Then you can notice like this is most common manifestation. Then some people, they will develop intussusception, they can develop testicular torsion, scrotal swelling, there can be blood in stool. So similar feature can be there in cryoglobulinic also. Now coming to joint involvement, you can see here you will see patient will have involvement of a knee joint mainly.
Basically, it's affect large joints. Sometimes you can see migratory arthritis, and you will see non-deforming, and generally less than 2 joints are involved. So we call this oligoarthritis. In case of, I can say, cryoglobulinemic, you will see here patient will have generally SLE-like arthritis. So here you will see SLE-like. SLE-like means it is again non-deforming arthritis. SLE-like arthritis, and most people, they will have arthritis, and like SLE, here also you will see these patients will have muscle pain. There will be myalgia. So it is something which is associated with myalgia. Then understand this thing. If you ask me kidney involvement, so in IgA nephropathy, in IgA vasculitis, you can guess the name IgA. So this is something which is related to IgA nephropathy. So this will increase the risk of IgA nephropathy, and I told you what IgA nephropathy we call. This is actually most common cause of nephritic syndrome worldwide, IgA nephropathy, and this is something we call this. So any nephritic syndrome later on, it can convert into a more complex form of nephritic syndrome, and more complex form of nephritic syndrome is called as RPGN. RPGN is rapid progressive glomerulonephritis. But if you ask me about cryoglobulinic vasculitis, it is something which is associated with MPGN, membrane proliferative glomerulonephritis. The reason is, understand this thing, it is having something related to hepatitis C. That's a chronic hepatitis. So chronic hepatitis will increase the risk of MPGN as well. So it is associated with MPGN. Then they ask you, this IgA vasculitis, it is not associated with any infection. So answer is here is no. But if you see essential mixed cryoglobulinemia, here you will see some associated infection like hepatitis C, right? Then just also remember, like it can also be seen, some cases are seen with hepatitis B also. So in Harrison it is mentioned like it is related to both hepatitis C as well as hepatitis B, right? So basically we have 3 types of cryoglobulins. So we have type 1, type 2 and type 3. So understand this thing, in this type 1 and type 2, these are monoclonal. But this type 1 has nothing to do with rheumatology. Type 1 basically we see where in a patient like who is having Waldenstone macroglobulinemia. So that is basically a concern of rheumatology. So in this essential mixed cryoglobulinemia, you will see type 2 and type 3 cryoglobulins. And just remember this type 1, it's a part of hematology. Hematology means Waldenstone macroglobulinemia. Now coming to cryoglobulin types which we see in HSP. So there is no cryoglobulins in HSP. In Henoch purpura, you will not see any cryoglobulins. And how we treat this? So they ask you, in Henoch purpura, the drug of choice will be steroid. So this was a question which came in last year, 2024 INICET exam. Like normally what we see HSP patient, Henoch purpura, it is a self-limiting disease. Self-limiting disease. Suppose if it is not self-limiting, suppose you can give some multivitamin to that child for or you can say multivitamin, calcium, or some I can say immunoboosters, or it will give nothing, it will be self-limiting, it will heal on its own. But if it is not self-limiting, or if this child is having like any sort of GI bleed, or I can say this is having severe abdominal pain. So these are the indication to start steroid. So this question came in exam. So in steroid also we give here low dose. So normal adult dose we give 1 gram per kg per day. Here we give 0.25 to 0.5 mg per kg. So understand this thing, they ask you what is indication of steroid. When it is not self-limiting, when the child is having severe GI, severe abdominal pain or GI bleeding. So steroid basically, why we give this for even one more condition I will say, severe joint pain. So severe joint pain, or I can say severe abdominal pain, or I can say GI bleeding. In these scenarios, just remember the word severe is needed before steroid, because in case of mild pain we can just simply give PCM, that's it. Then what they ask you, suppose, what about the prognosis? So overall, it's a self-limiting condition. So HSP will always have good prognosis. Let's now talk about treatment of mixed cryoglobulinemia. So generally, it is associated with hepatitis C. So how you manage hepatitis C? So we will treat hepatitis C. So treatment of hepatitis C. So in hepatitis C, generally what we give combination of two drugs. So we give sofosbuvir plus daclatasvir. Or sometimes we can choose sofosbuvir plus velpatasvir. So we need to give sofosbuvir, daclatasvir, and if it is severe, if it is not controlled with this, then we need to add rituximab. So this is something which you have to remember about the difference between, I can say, IgA vasculitis and essential mixed cryoglobulinemia. Now let's talk about one by one about each of these vasculitis. The first is first large vessel vasculitis, which we are discussing, is giant cell arthritis. So giant cell arthritis, understand, we also call this temporal arthritis. So they ask you, like, generally the patient is more than 50. So very few cases are seen which are in the 50 to 60 age group. So just I will say, even like in some books it is written a rule of 60. So what is rule of 60? You have to remember. Rule of 60 you have to remember for giant cell arthritis. So what is rule of 60? Understand this thing. Generally it is seen in female, and these female are above 60 years. Then you will see patient ESR. Normally patient you will see when you have some infection, then ESR will go up to 20, 30. In multiple myeloma it can go even above 100. So here generally remember, here ESR is more than 60. In multiple myeloma it is more than even 100. And how we treat this? So for treatment we give 60 milligram prednisolone daily. And how the 60 milligram came? Average Indian body weight is 60 kg, so 1 mg per kg, that means 60. Simple. So just remember 60, 60, 60 means female above 60, ESR above 60, treatment will be 60 milligram prednisolone. Now coming to arteries involved. So what are the arteries involved? So most common vessel, most common will be superficial temporal artery. So this question came many times in exam. So most common artery involved will be superficial temporal artery. Then it can involve vertebral artery, it can involve ophthalmic artery, it can involve posterior ciliary artery. So what will be symptom? So symptom means patient will have a new onset headache in this area. In this area means in this temporal area. So there will be new onset temporal headache. New onset temporal headache is actually, I can say, one of the earliest complaint. Then patient will have increase in ESR, and I told you this ESR value in most cases you will see it is more than 60. So now see, when you have high ESR, we will think that patient is having fever, but there is no as such fever. Then patient will have jaw claudication. There will be jaw claudication means you can see sometime intermittent pain in the jaw. So this is most specific symptom. But if you ask me what is most common symptom, so most common symptom will be headache. So most specific symptom, just mark my words, it will be jaw claudication, and most specific symptom, I will say, that will be your headache. Now what else you can notice? Like there is this involvement of a temporal artery, so you can find temporal artery tenderness. Temporal artery tenderness. You can find a temporal artery tenderness. And sometime you can say ophthalmic artery is involved. When ophthalmic artery is involved, then patient will develop visual symptom. There will be visual symptom. So what visual symptoms he or she can develop? So first you can notice, like patient will develop altitudinal hemianopia. So patient can develop altitudinal hemianopia. So later on, slowly, understand, slowly this can lead to visual blurring, and ultimately there is risk of blindness. So if you ask me what is most dangerous complication, so most dangerous complication will be risk of blindness. Then remember, many patients are having a complication, so they will complain of pain in shoulder muscles, pain in calf muscles. So that is called multiple muscle pain. Like we see in rheumatoid arthritis, we call this polymyalgia rheumatica. So again, they give you a clinical case and they ask you which vasculitis is associated with polymyalgia rheumatica. It is temporary arthritis. Now understand how we make a diagnosis. So in vasculitis there is a rule. either find some antibody. If there's no antibody, then do biopsy. So understand this thing, gold standard will be biopsy. In biopsy, what you will find, it is a granulomatoid inflammation. You can find granuloma, you can find giant cells, you can find, I can say, fragmentation of internal elastic lamina. But one thing understand, suppose this is the temporal artery biopsy, you can take sample. So here you will notice inflammation. Inflammation is segmental and skipping in nature. Means you can see inflammation area, then some normal area of inflammation. So you can see inflammation is segmental and skipping. So suppose if I take biopsy of this much sample, what I will get? What I will get if I take biopsy of this much sample? I will get nothing. So I need to take at least this much sample of biopsy. So this much sample of biopsy is needed. So what we call this long segment biopsy. So normally it is recommended to take 3 to 5 centimeter, at least minimum 1 centimeter. So just remember, it is 3 to 5 centimeters recommended, or always remember we should take at least 1 centimeter biopsy. We call this long segment biopsy. So they ask you like what is the range of biopsy? We should always do at least more than 1 centimeter biopsy, or we call this long segment biopsy. Okay, now coming to the finding, you can see a cord like thicken. So you can see these are thick cord like temporal artery. This is the finding, and because of this, patient will develop headache and jaw claudication. Then when you do biopsy, for biopsy, understand this thing, this elastin fibers. For elastin fibers, what we can use this von der Hofs-Gießen stain. So this is sometimes they can ask in pathology as an image-based question. Now understand this thing, how we treat. I told you loss 60, so drug of choice. Drug of choice in this condition will be steroid. And the dose I told you, that is 1 mg per kg per day. 1 mg per kg per day of prednisolone. That means it will be on average 60 kg to 60 mg. But remember, steroid we start immediately whenever we suspect. Why? Because if slight delay, that can lead to permanent blindness. So that's why we start steroid as soon as possible. Suppose you have started steroid, but you cannot give steroid for long term because steroid will always have risk of Cushing syndrome. So in case of relapse, what we use a drug called tocilizumab. Now tell me pharmacology, what is mechanism of action of this drug? The same tocilizumab we have used in COVID, we have also used this drug in rheumatoid arthritis. Just remember, it is interleukin 6 inhibitor. Minus sign is inhibition. This is inhibiting interleukin 6. Now compared to next vasculitis, that is your Takayasu arthritis. So Takayasu, just remember, it will always affect young patient. Young patient means patient will always be less than 40. So patient will always be less than 40 means it is affecting your young patient. So another thing, it will involve non-specific branch of aorta. So because of such involvement, non-specific branch of aorta, we also call this as non-specific aortoarthritis. Non-specific aortoarthritis. So it's involving non-specific branch of aorta, or I can say it can cause aortic arch syndrome. Aortic arch syndrome. Now they ask you, in aorta we have a lot of branches. So what is most common branch of aorta that's it's involving? So remember, it is left subclavian artery. So left subclavian artery, this is most common artery that's involved. So this is also a question which came in exam. Then remember, it can involve, I can say, aorta, other arteries, it can involve mesenteric artery, it can involve coronary artery, but remember, mainly it's involving left subclavian artery. Now, what they ask you, suppose patient, there is a chance like this can involve kidney vessels. So it can cause renal artery stenosis. It can cause renal artery stenosis because there is involvement of renal artery. So there is a chance people will develop renovascular hypertension. In fact, I can say, suppose if I ask you what is most common cause, the most common cause of renovascular hypertension in India. In fact, not in India, in Asian countries, I will say Asian countries. So just I am writing here, most common cause of renovascular hypertension in India or in Asian countries, the answer is Takayasu. So whenever you see like involvement of aorta, there is always a discrepancy in upper and lower limb pulse and BP, because BP we measure where? In artery. So understand, there will be asymmetric pulse and BP in upper and lower limb. In upper limb and lower limb. Even sometime in both hands there will be variation. So we can diagnose by different criteria. In India, we use modified Sharma's criteria. They ask you like, what are the DDs for BP difference? So in simple language, I can say, wherever you see a problem in aorta, you can see discrepancy in pulse and BP of upper and lower limb, right? So in aortic, in simple language, BP difference you will see in both upper limb and upper and lower limb, where whenever you have aortic arch problem or in aorta defect. So where we see aorta defect? So aorta defect, where we can see in Takayasu one. You can see this in a patient with, I can say, coarctation of aorta, especially which type? Preductal type. Preductal coarctation of aorta. You can see this in a patient of aortic dissection. And just remember, aortic dissection is most common cause of death in the patient with Marfan syndrome. Then you can see like sometime supravalvular aortic stenosis. We also call this Williams syndrome. So these are the differential diagnosis. In simple language, I can say wherever we have aortic arch problem, we will see discrepancy in upper and lower limb, and even there will be discrepancy in both upper limb. You see right and left pulse BP will be different. The point is how you will make a diagnosis. What we do to make a diagnosis. So understand this thing. Takayasu is something which is involving deeper vessels. So we cannot do a biopsy of aorta. So to make a diagnosis, what we need, we will do CT and GTR. We will do CT and GTR, and how we are going to treat. So treatment will be same. We will give steroid. So treatment will be like temporal. So this is, you can notice like in Takayasu, you can see these findings. Like this is CT and GTR image which they ask in exam. So in CT and GTR, you can make a diagnosis of Takayasu. Okay, so after Takayasu, what they ask you? They ask you question on medium vessel vasculitis, that is a Berger disease. So in Berger disease, what is important? It's a disease which start with artery. It start with artery, then it will affect your vein, then it will affect your nerve. So disease will start with artery, then vein, then nerve. What is not involved, so what is spared here? So this will spare your lymphatics. Lymphatics, or I can say lymph nodes, are not involved. So this question came in exam. So Berger disease is also called as tau. Tau means thromboangiitis obliterans. So what we can see in this condition, how you make a diagnosis. So understand, here the question is always like a patient who is a middle-aged man. So mostly it will affect a middle-aged man, and this person will be like a heavy smoker. There will be history of heavy smoking. The patient will develop intermittent claudication, there will be rest pain, there can be gangrene, and even because nerves are involved, then you will find patient will have neuropathic symptoms. Neuropathic symptom means patient can develop numbness, tingling sensation, where in your upper limb or lower limb. So how you will make a diagnosis in biopsy? You can find glomerular inflammation, you can see neutrophilic microabscess, and it involves all three structure. All three structure means artery, then vein, then nerve. First artery, then vein, then nerve. And what they ask you, what is not involved? Just remember, lymph nodes. Lymph nodes are not involved. So lymph nodes are not involved in a patient with Berger disease. Then what they ask you, suppose, what is a most common artery? They ask you what is most common artery. So most common artery, what it's involving? So mainly it will affect your radial artery. And after radial, understand it can involve your tibial artery. Radial, then tibial. Okay, now look at this. What question they ask you, like on angiography, what you will find? So you can notice like a corkscrew pattern of collateral is seen. A corkscrew collaterals blood vessels are formed. We call this corkscrew collaterals. These are seen on angiography. So how we are going to treat this? So this you can notice like a patient who is having a Berger disease. You can notice in Berger disease what we see. You see like arteries, veins and nerves all are affected. Now how you are going to treat this? So understand this thing, diagnosis is clinical. Diagnosis clinical, and how we are going to treat this. For treatment, the first thing will be a complete smoking cessation. complete smoking cessation. So what you will do for this? Can we give nicotine replacement therapy? Nicotine chewing gum, nicotine patch? Yes or no? So nicotine replacement therapy can we give? It is contraindicated. Why? Understand this thing. It is due to nicotine. Suppose why we are chewing nicotine chewing gums, because that smoke should not, that gum is also having nicotine. So when you chew that gum, so remember, nicotine is not going into your lungs, but ultimately is going to your blood. So this chewing gum also have nicotine. It's not a disease of lung. So remember, any form of nicotine, means pan masala, gutka, chewing gums, Nicotex, patch, then I can say nicotine spray, then mouth dissolving strips, any for the hookah, vape, any form of nicotine is contraindicated. Then what we give a drug called pentoxifylline. Pentoxifylline, it will have antioxidant action. And suppose if patient develop gangrene, in that case what we can do? Then we have to remove the gangrene, we have to do debridement. And sometimes like debridement is not sufficient, then we have to do amputation. So this is about your Buerger disease. Okay. Then let's talk about PAN. PAN means polyarthritis nodosa. So we ask you, PAN is having which type of hypersensitivity? So remember, PAN is having immune complex. So PAN is having type 3 hypersensitivity. Now coming to PAN, understand what is not involved. So in PAN, it is a multisystemic disease. Multisystemic means multiple organ system. Suppose if it's involving the skin, so patient can develop skin rash. If it's involving brain, then you can see some neurological symptom. Brain arteries are involved. Then it can involve heart vessels, then patient can develop subcardiac manifestation. GIT, then patient can develop abdominal pain. So what is not involved? Just remember, lung parenchyma is not involved and renal parenchyma is not involved. So very, very important question. They ask you, PAN involved all except lung. Is it clear? In kidney, like parenchyma is not involved, but other part can be involved. So PAN is called medium vessel vasculitis. It is, I can say, a multisystemic medium vessel vasculitis. Medium vessel vasculitis. Now they ask you what you find in biopsy. So in biopsy, you will find like all layers are involved. So there is a transmural necrotizing inflammation. Transmural necrotizing inflammation. And in this inflammation, you will find a type of necrosis. So which type of necrosis we find in immune complex? In immune complex means type 3. You will find fibrinoid necrosis. So there will be fibrinoid necrosis. Now they ask you this PAN. This PAN is associated with hepatitis B, or I can say HBS antigen. Hepatitis B surface antigen in 30% of patients. So this will increase risk of hepatitis B. It will increase risk of hepatitis B. Then just remember, PAN will also increase risk of hairy cell leukemia. So hairy cell leukemia is also associated with PAN. Then patient can develop hypertension. So you can notice here, you can see this pink color is fibrinoid necrosis. This is classically seen in a patient with PAN, polyarthritis nodosa. Okay. And this area is called unaffected area, so it will look blue in color. Okay, one more interesting fact about PAN which never came, but I am expecting this question. They can ask an exam. So mostly what we see, how people die because of vasculitis is involvement of heart. Mainly if coronary arteries or any heart arteries are involved, then patient can die. Here the interesting part is cause of death is not heart involvement. Cause of death means is due to involvement of lungs, kidney. No, it is due to involvement of GIT vessels. So understand this thing, it can cause GIT infarction. So GIT infarction that can cause perforation, that can cause perforating peritonitis. That is the leading cause of death in PAN. Right? So patient die because of GIT infarction, GI vessels involved. This is about polyarthritis nodosa. Now let's talk about small vessel vasculitis. So in small vessel, first is gallomatous with polyangiitis, and this is like this was previously called as vaginous gallomatosis. So vaginous, what are the findings you will notice? You will notice like it is, patient will have this midline nasal deformity, and you can see a thick walled cavitating nodule in the lungs. These nodules you will find where? In the lungs. This nasal deformity of midline, this is what we call this as saddle nose. This nose is called as saddle. This a depressed nose, what we call saddle nose. Now tell me where we get saddle toes. Saddle nose we have discussed. So where we get saddle toes. So saddle toes, understand, it is something which we get in a patient of rheumatoid arthritis in adult, and in children we get saddle toes in a patient of Down syndrome. Then patient can develop diffuse alveolar hemorrhage and patient will have chance of RPGN. Now they ask you RPGN, we have different types of RPGN. So generally we have type 1, type 2 that occur when any glomerular disease is converting into RPGN. When a non-glomerular condition or a non-kidney condition is converting into RPGN, we call this type 3 RPGN. Type 3 RPGN, also called as pauci-immune RPGN. We call this pauci-immune RPGN. And remember, in 95% cases, we will find Synovitis. Okay, so understand vagus will have a triad, like there is involvement of upper respiratory tract infection. So you can see upper respiratory tract involvement, the patient can develop sinusitis, nasal polyp. LRTI, patient can develop pneumonia, and kidney, there will be RPGN. Suppose if I say there is no upper respiratory tract involvement, there is only these two findings. Let's understand this. Suppose if you see only these two findings, then this is not vagus, this is your good pasture syndrome. So the closest differential diagnosis will be good pasture syndrome. So upper respiratory tract inflammation and involvement, that means sinusitis, rhinitis. Lower means pneumonia, granulomas, so patient will develop hemoptysis. And kidney involvement means RPGN, then it will have hematuria. So understand this thing. All three finding, if you see all three finding, so this is seen in vaginous granulomatosis. If upper is not given, lower and kidney, lower respiratory tract and kidney, that will be your good pasture syndrome. Yeah.
Okay, now we'll talk about the most common vasculitis and the most important which they ask in MCQ, that is Hannock-Schollen purpura. So I'm monitoring an exam paper from past 3 years. There is always a question on this vasculitis. This is called IgA vasculitis or Hannock-Schollen purpura. In short, we call this HSP. Now, understand this thing, how patient will come to you. So there will be a non-thrombocytopenic palpable purpura. And this will be where? This will be generally on lower lip. So there will be a non-palpable, I can say purpuric rash that we see in patient. And it is seen in almost most people. We also call this leukocytoclastic vasculitis, right? And there is no ANCA here. Now, other than this purpuric rash, remember this child will be having abdominal pain. So most common presentation, what we call this abdominal angina. Most common will be abdominal angina, or patient will come to you with abdominal pain. Simple, we call it abdominal pain. So patient will have severe abdominal pain. Then sometimes you can notice there is a chance like this baby can develop intussusception. So if they ask you like what is most dangerous complication, they can develop is intussusception. Then there can be purpura, sometimes testicular torsion, scrotal swelling, sometimes you will see blood in stool, and even sometimes you can see there will be blood in urine, means there will be hematuria. So how we will manage? So initially, understand this thing, it is like a mild disease, so we don't have to do much, means treatment is self-limiting and diagnosis is clinical. So diagnosis is clinical and treatment, it is a self-limiting condition. But remember, if it is not self-limiting, then what we do? Then we start a low dose steroid. Then we start steroid on low doses. So corticosteroids, they have improved outcomes. And when we give corticosteroids, suppose when it is any patient is having GI complication like GI bleed, abdominal pain, and when it is not self-limiting. So this was the last year INICET question. Like what is the indication to start steroid?
So first indication, understand this thing, when patient is having severe GI bleed, there is severe abdominal pain, and it is not circulating. In that case, we will give steroid. After HSP, now let's talk about Behçet's disease. So Behçet disease, we also call this as Silk Road disease or Silk Root disease. You can say Silk Road or Silk Root disease. So understand, in this disease you will notice like patient will have recurrent oral and recurrent genital ulcers. So both these ulcers will be recurrent, and remember, both these ulcers are also painful. These are also painful. Now what they ask you what is the HLA that we see. So HLA that we see is HLA B5 and HLA B51. So that is the HLA which we see, and this question came multiple time in your exam. So now what they ask you, like patient will have recurrent oral and genital ulcers. So one specific feature I will say about these ulcers. So initially when this disease came, so it mimic an STD, like sexually transmitted disease. But the feature is you will not see the ulcer in the glands. In STD you will see ulcer where? In the glands. Here you will see ulcer not in glans penis. Means you can see the ulcer in the shaft of penis but not in the glands. Then they ask you like this is how we make a diagnosis. So diagnosis is clinical. To make a diagnosis we need clinical criteria. And what we do, we will do a simple test. That simple test, you will insert a sterile needle in the hand of a patient, sterile needle. So this is what we call this pathergy test. This test is called as pathergy test. So suppose if I insert a needle in your hand, maybe a slight small bump is there and it will disappear after few hours. But if this bump persists, that is what we call, you can see it is nothing, it is a hypersensitivity to scratch or intradermal saline or needle. Now what they ask you suppose what are the ocular manifestations. So understand this thing, ocular manifestation means patient can develop a chronic relapsing bilateral panuveitis. Bilateral panuveitis. So this is the ophthalmological manifestation, and other than this you can see patient can develop retinal vasculitis. So retinal vasculitis is very classical for Behçet disease. Now coming to antibodies, so which antibody you will see, so you can find antibody that is alpha enolase, and in some cases you can also find ASCA. Now can you please tell me where we get ASCA in GIT? Yes, come on, ASCA is also seen in Crohn's disease. Yes, very good. So now we can take biopsy from the lesion, but again generally we can make a diagnosis based on clinical grounds, so biopsy is not needed. But when you take biopsy you will find neutrophilic vascular reaction. So here you can see this is patient will have multiple oral ulcers. You can see like uveitis, eye manifestation, and this is what we call this a positive pathergy test. So this is eye manifestation. This is a positive pathergy test. So these are the findings that we see in a patient of Behçet disease. Thank you so much. Now let's talk about PUO. We also call this FUO or PUO, means pyrexia of unknown origin. So what is this PUO? So now see, patient is having fever. So this fever I can say it is more than 38.3. Fever more than 38.3 degrees Celsius in Fahrenheit. In Fahrenheit we call this more than 101. And this fever, understand this thing, it will be on at least 2 occasions. On 2 or more occasions. So suppose a patient who is having fever on 2 or more occasions, and this duration of fever should be more than 3 weeks. So from past 3 weeks he is having fever. So generally why we develop fever? There should be some reason. There should be some infection, or your body immunity is very low. There is no immunocompromised state here. So make sure before making a diagnosis, labeling a person as PUO, we should say he should not have any immunocompromised state. So diagnosis, it's remain uncertain, because it is something like which is very difficult to make a diagnosis, because we have to rule out every testing. So what question they ask you on PUO is on definition. So definition means more than 38.3 degrees Celsius on 2 or more occasion and duration more than 3 weeks. So this is about your PUO.